Metropolitan Local Aboriginal Land Council elders and members would like to welcome everyone here to this beautiful land of the Gadigal for the National Medicines Symposium. As we understand in our communities, Aboriginal communities and First Nations communities, that diabetes is a problem within our communities and we need to address it. So it's very important that participating in this, and we want everyone to have a great time here, a safe stay, a safe journey to your family and loved ones and community out there. And we'd also like to send a big thank you to all those that we're streaming to around the world, because it is so important to deliver medicine in the appropriate way, always with dignity and respect. And also when you remember with regional remote communities that there is a consideration of what bush medicine they may be taking, and also incorporate their carers, and they might need someone else in the room. So always was, always will be Aboriginal land never ceded. Good luck with the symposium. Thank you.
Welcome to the National Medicine Symposium for 2025. I'm your host, Andrew McLaughlin. I'm the Head of School and Dean of Pharmacy at the University of Sydney, and I'm coming to you from the land of the Gadigal. I'm pleased to be here today as we explore one of the most pressing challenges facing Australians. Safe and appropriate use of medicines in diabetes management begins with understanding the role of medicines in treating diabetes, while also recognising the importance of nutrition and physical activity, both as preventative and complementary measures. Diabetes is a chronic, complex condition that can affect individuals of all ages. If left unmanaged, it can lead to serious health complications. The most effective management plans are those that are personalised and also consider an individual's cultural beliefs, their lifestyle, and their preferences. These plans should also be carefully integrated into the individual's daily routine to ensure sustainable care. Today, you'll hear from experts, clinicians, and people with the lived experience who can discuss the emerging issues, current challenges for medicine safety in people living with diabetes. We'll explore innovative strategies and initiatives aimed at enhancing safe and appropriate use of medicines in people with diabetes to improve their care, to improve the quality of life of all Australians, hopefully inspiring you to consider how these apply to your practice and the healthcare setting where you work. Firstly, we're joined by the Minister for Health and Ageing and Minister for Disability and the National Disability Insurance Scheme, the Honourable Mark Butler.
Well, good morning, everyone. I want to acknowledge the Ngunnawal people as the traditional owners of the land where I'm recording this, and recognise any other people or families with connection to the lands of the ACT and its region. And I extend that respect to First Nations people attending the symposium today. Thank you to the Australian Commission on Safety and Quality in Healthcare for hosting this symposium. And thank you to all of those contributing to today's events. Whether as part of the outstanding lineup of presenters or the thousands of people watching and hoping to learn more about quality use of medicines in people with diabetes. I'd like to give a special mention to those with lived experiences through your courage in sharing your stories that we learn about how we can improve our healthcare system. Our government is committed to ensuring that every Australian can access quality healthcare when they need it most. Clearly, a big part of this is having access to the best medicines for their needs. But if it was that simple, of course, these symposia wouldn't exist. And with a complex chronic condition like diabetes, it's an even bigger challenge. But getting it right can have a significant impact on the day-to-day lives of people who live with this chronic disease. Diabetes, we know, is a major health issue for our nation. Its prevalence has slowly but steadily increased over the past 20 years, from 3.3% in 2001 to 5.3% of the population in 2022. That's 1.3 million people, or more than 1 in 20 Australians. Diabetes, we now know, is one of the 10 leading causes of death in Australia, and it's a contributing factor in other deaths, such as those caused by sepsis, where 1 in 3 cases have background diabetes. But sadly, it's even worse for First Nations people. 1 in 6 First Nations adults have diabetes, and rates are even higher among those living in remote Australia. Ensuring First Nations people have access to the best medication and treatment alongside improving prevention is absolutely critical for closing the gap on health and mortality. Diabetes is also a huge source of pain and disability, particularly through diabetes-related foot disease. Astonishingly, the disease burden caused by this foot disease globally is about the same as dementia and breast cancer combined. It's vital we reduce diabetes-related complications by giving each patient personal, effective and safe treatment. Medicines are at the centre of this because most people living with diabetes will rely on medication for the rest of their lives. Our government has a proud record of delivering for Australians living with diabetes. We understand how important it is for people with diabetes to have access to a stable supply of products and medications to manage their illness. That is why we secured the listing of fast-acting insulin Fiasp Penfill on the PBS. We delivered on our election commitment to give the 130,000 Australians with type 1 diabetes access to subsidised CGM products under the National Diabetes Services Scheme. And we expanded access to the insulin pump program. We're focused on strengthening Medicare and general practice, which are at the heart of good diabetes care. Getting in to see your doctor and being able to afford your diabetes medication is absolutely critical in managing diabetes. This has been our priority as we've tripled the bulk billing incentive and made medicines even cheaper. Diabetes care is evolving and there is much to consider, so I'm really sure this will be a highly rewarding symposium. Thank you for your commitment to better care for people living with diabetes and for all Australians. Very best wishes.
Thank you, Minister. It's my pleasure now to introduce Professor Anne Duggan. Anne is the Chief Executive Officer at the Australian Commission on Safety and Quality in Healthcare and is a highly respected gastroenterologist with significant leadership experience in a range of healthcare settings. Anne is also Conjoint Professor at the School of Medicine and Public Health, University of Newcastle. Anne is passionate about improving healthcare services through sharing knowledge and collaborating across the health system. Welcome, Anne.
Good morning and welcome. On behalf of the Australian Commission on Safety and Quality in Healthcare, I'm delighted to open the National Medicine Symposium 2025. This annual symposium is a cornerstone of Australia's medicine safety conversation. We bring together people with lived experience, clinicians, researchers and policymakers to address some of the most pressing challenges in healthcare. As Minister Butler highlighted, diabetes is one of Australia's most urgent and complex health issues. More than 1.5 million Australians live with diabetes, and chronic conditions like this are an underlying or associated cause of 90% of all deaths in Australia. The impact of diabetes extends far beyond blood sugar control. The Commission's National Sepsis Program found that nearly 1 in 3 hospital admissions involving sepsis also involved a patient with diabetes, a condition that makes sepsis harder to treat. Safe administration of insulin remains a critical challenge. Despite advances in dosing technology, hospital admissions from accidental overdoses remain unacceptably high. Adding to this was the recent discontinuation of multiple insulin products. The Commission is working with the Therapeutic Goods Administration, Diabetes Australia and the National Aboriginal Community Controlled Health Organisation to address insulin shortages and discontinuations, ensuring equitable access for all Australians. Another issue we face today is the rising use of GLP-1 analogues for indications other than diabetes, which requires careful assessment of this evidence and the risk of harm. It's essential we adopt a safety and quality lens to ensure the availability of these medicines for people who need them most. But there is also tremendous opportunity. The symposium will focus on quality use of diabetes medicines and how we can deliver safe, effective and person-centred care for people with diabetes. Care that considers comorbidities, transitions of care and individual preferences. Today you'll hear from some of the country's leading experts, including clinicians, researchers and people living with diabetes. Together we'll discuss how to integrate new technologies like continuous glucose monitors and insulin pumps into everyday care. We'll talk about structural barriers to care and how to provide culturally safe, inclusive services, especially in Aboriginal and Torres Strait Islander communities. And we'll look at the vital role of non-pharmacological approaches to diabetes management, including nutrition, exercise and mental health. But most importantly, we'll talk about empowering people to manage their own diabetes. Earlier this year, the Commission released results from the Paris Health Survey which highlighted that people with chronic conditions, including diabetes, often lack confidence in managing their health, particularly when dealing with multiple comorbidities. The findings reinforce what we all know. The foundation of care is a trusted long-term relationship with primary care providers. Supporting people to self-manage in partnership with their clinicians is essential in improving outcomes. I want to thank our speakers and organisers, especially those with lived experience who will share their personal stories today. Your expertise and insights makes this symposium a unique forum. To everyone joining us online, your engagement is critical. The ideas and actions we discuss today can help shape the future of diabetes care, reducing harm, improving quality of life and ensuring medicines are used safely and effectively. Together we can build a healthcare system where quality use of medicines supports every Australian with diabetes to live well. Thank you, and I look forward to the discussions ahead.
Thank you, Anne. And thank you to everyone who is joining us today from around Australia, and especially for those who have submitted questions. They've been very useful in planning today's event. Now let's learn about the burden of diabetes in Australia, including the prevalence, incidence and cost of diabetes in the Australian health system, with Professor Diana Magliano.
Hello, my name is Professor Diana Magliano. I'm delighted to be able to speak to you today on behalf of the National Medicine Symposium 2025. And today I'm going to talk to you about the diabetes landscape in Australia. So in the next 15 minutes or so, I'm going to tell you about the global burden of diabetes. I'll then move on to the state of diabetes in Australia, and I'll address prevalence, incidence of type 1 and type 2 and gestational diabetes. And then I'll talk a little bit about diabetes in First Nation Australians. I'll then move on to some diabetes complications work that we've done recently here at Baker, and then I'll finish off by talking about the cost of diabetes. So diabetes is a chronic condition where the body either doesn't produce enough insulin or can't effectively use the insulin it produces. And that leads to high blood glucose, which is the characteristic or the hallmark of diabetes. There are several types of diabetes, including type 1 diabetes and type 2 diabetes. Type 2 diabetes is what we call a lifestyle diabetes and occurs mainly in the Middle Ages, where people, due to their lifestyle, have developed abnormal glucose tolerance and will need to take some medications to keep their glucose under control. The other type of diabetes is autoimmune diabetes, type 1 diabetes, where the pancreas has completely stopped producing insulin, and these people need insulin to survive. Now let's start talking about some data. These data here I present from the International Diabetes Federation Diabetes Atlas, which is an authoritative organisation which produces this diabetes report every couple of years. And what it does, or what we do, because I chair this program, we estimate the number of people with diabetes globally and in every country of the world. Now, these data here tell a sobering story. In the year 2024, diabetes prevalence globally is at 11%, or 1 in 9 adults have diabetes globally. In the whole world, we have 580 million people with diabetes, that's adults, and we expect this number will increase to 853 million of people with diabetes by 2050. And that's an increase of 45% since 2021. We will see rises of diabetes in adults in every region of the world, as you see in this picture. And we'll see the largest increases to occur in Africa, Middle East, and Southeast Asia. And these are the lower or middle income regions of the world. The increasing diabetes reported here from the Atlas are mainly due to changes in demography and urbanisation. And when we do our modelling, we assume that the age-specific prevalence is constant over time. The drivers of diabetes are, of course, as you may know, rising levels of obesity, unhealthy diets, and widespread physical inactivity. Now, let's move on to some Australian data. In Australia, there are 1.5 million Australians who have diagnosed diabetes, and these data come from Diabetes Australia. Now, these data are from an organisation which runs the National Diabetes Service Scheme, which is like our diabetes registry. So when someone develops diabetes in Australia, their doctor or their nurse register them on this scheme, and this allows them to get subsidies to treat their diabetes. And currently, we have 1.5 million Australians with diabetes on this scheme. And we also think there's another 500,000 people who have diabetes and who are unaware of it. So together, that leads to a total prevalence of 7.4% of Australians with diabetes. The diabetes prevalence is slightly higher in males versus females. Now, the Diabetes Atlas, which is the organisation I spoke about previously, estimates the prevalence of diabetes in Australia to increase to 8.7% by the year 2050. These data show you what prevalence does across age. Now, most of the diabetes we have in the world is type 2 diabetes, and this is a disease of people of the middle ages. And as you can see, diabetes prevalence increases with age, and by people's seventh decades in Australia, about 15% of adults will have diabetes. That's 1 in every 6 Australian adults. Here are some similar data, but in an Indigenous population. And I've used this population from the Northern Territory, but I want to acknowledge the fact that diabetes in Indigenous populations, the prevalence will vary depending on what part of Australia we're measuring prevalence. But here you can see prevalence, which is all cases of diabetes, on the left-hand part of the slide, and incidence, which is new cases of diabetes, on the right-hand slide. And these data are from 2018-19. And these across age, the data tell a similar story, but you must, of course, notice that the absolute magnitude of prevalence in Indigenous Australians is much higher. On the left, you can see by the 6th decade, over half of Indigenous people will have diabetes, and they mainly suffer from type 2 diabetes, and it's slightly higher in females versus males, when in the general population it is slightly higher in males versus females. Now, to illustrate the difference in the magnitude of diabetes prevalence in First Nation peoples versus the general population, I've plotted on both sides of this slide prevalence by age. On the my left, in First Nation people, and in the right, in blue, prevalence in the general population. And you can see the pattern of the graph is the same. Diabetes is increasing by age group up to a maximum highest in the 60s and the 70s. But you can clearly see in the First Nation data, in the First Nations people, the magnitude of diabetes prevalence is sometimes threefold higher than it is in the general population. And this tells us how much greater risk they are developing diabetes versus the general population Australians. And it's particularly obvious in the younger age groups. Now, I've mentioned a lot about type 2 diabetes. Now, here are some data on type 1 diabetes. Now, just reminding you that type 1 diabetes is an autoimmune condition where antibodies develop and destroy the beta cells in the pancreas, which produce insulin for survival. And so people with type 1 diabetes need insulin to survive. And weak without insulin, and that would lead to their demise. Now, the new cases of type 1 diabetes in Australia roughly is about 4,200 each year, and that was the number for 2025. And our total number of cases on that National Diabetes Service Scheme of type 1 diabetes is about 117,000 at any one time. But you need to be aware that with data on the registry, the National Diabetes Service Scheme, sometimes there's a little bit of misclassification between type 1 and type 2 diabetes. Now, these data suggest that the prevalence of type 1 diabetes in Australia is about just under 0.5%, and this is pretty consistent with data from a first world country. For prevalence of type 1 diabetes, we see that at about 0.5%, and we rank quite highly in prevalence of diabetes across the world, somewhere after Scandinavia and Italy. Now, on the right-hand slide, you see prevalence of type 1 diabetes by age, and you can see there's a different age pattern with type 1 diabetes versus type 2 diabetes, and you all will be aware that type 1 diabetes is a common disease in childhood, and you can see the peak incidence of type 1 diabetes in 0 to 9 and 10 to 19-year-olds. It sort of plateaus off as people get older, but you do still see type 1 diabetes in older people. And because technology and treatment is so much better than it used to be, we're having people survive to old ages with type 1 diabetes. Now I'm going to talk to you about hyperglycemia in pregnancy, and this is akin to gestational diabetes. And so these are data from the International Diabetes Federation Diabetes Atlas, and the prevalence of gestational diabetes, and this is diabetes which gets first detected during pregnancy, is about just under 15%. So 15% of all pregnancies in the age group of 20 to 49 will present with gestational diabetes. And in terms of live births affected by hyperglycemia in pregnancy, we have about 52,000 of these cases a year. Now, having hyperglycemia in pregnancy puts your baby at risk of many adverse outcomes, macrosomia, diabetes later in life for the baby and the mother, and other acute metabolic defects. And the reasons why we're seeing more and more gestational diabetes is twofold. People of non-white ethnic groups have a higher rate of gestational diabetes, and also women are having their babies a bit later in life, and it's also due to the higher levels of obesity than we've ever seen before. Now I'm going to tell you some good news about diabetes in Australia, and these are now some data on incidence of diagnosed type 2 diabetes in Australia over time, and incidence is the new cases of diabetes. And what you can see here in both men and women, and these are adults, you can see that over time from about 2005 to 2010, the incidence of the new cases of diabetes was increasing up to 2010, but then it started to slowly come down, and it comes down slightly more strongly in women than men. So this is a good news story and tells us that we're starting to heed the messages of healthy life, good diet, and better physical activity levels in the community. So prevention, perhaps, or health awareness is finally having some traction. So here are some data on the incidence of type 2 diabetes stratified by socioeconomic disadvantage and sex. And I've stratified it by 5 different levels of social disadvantage. Now, the black line in women and the purple line in men are the most disadvantaged folk in Australia, going down to the yellow, which is the least disadvantaged or the wealthiest people in Australia, and green on the right would be the wealthiest areas in Australia. So this measure of social economic disadvantage is a government measure, and it takes into account employment, education, and income of areas. So it's area-based. And what this slide shows you that those who are most disadvantaged, both men and women, have the highest level of type 2 diabetes incidence, and those who are the wealthiest or live and have the least disadvantage have the lowest level of type 2 diabetes incidence. But you can see the shape of the curves are all the same. So incidence goes up from 2005 to 2010, and then it starts to come down. So everyone is having the benefit from more education about healthy lifestyle and stronger levels of physical activities. But unfortunately, the news is not always good, because here's some more incidence data, and now I've graphed it from country of birth. So these data, again, come from the National Diabetes Service Scheme, and you can see in overall general populations in Australia, from the previous slide, in men and women, incidence was going down, but here in these groups, and these people were not born in Australia, incidence is not going down as much. And so you can see the yellow represents Australians, and on the women, yellow represents Australians, people from the UK, Canada, and US, and incidence is going down, and same on with the men. But you can see people born in the Pacific Islands, South Asia, North Africa, and the Middle East, and South and Central America, you can see that incidence has not come down in those population subgroups. And now I'm going to present you some data on diabetes complications. So once you get diabetes and you've had it for a while, the development of complications can be quite silent, and they can be quite associated with high degrees of mortality and morbidity. And the most common complications we see with type 2 diabetes and type 1 diabetes are heart attack, stroke, heart failure, amputations, and hyper and hypoglycemia. That's a low blood sugar and high blood sugar. And so let's look at the data on the left first. Amongst people with type 1 diabetes, you can see where there's a line through it, that means there's a significant increase or decrease. And so for type 1, for heart attacks and stroke, you can see there are small increases over time amongst people with type 1 diabetes. So it's not flat, but it's only increasing a little bit. And you can see with all the other outcomes on this slide, there is no significant increase or decrease, so it's stable. So that's a good news story. Then on the right, we have amongst people with type 2 diabetes, and the news is a bit better there. We see decreases in incidence of heart failure amongst people with type 2 diabetes and in myocardial infarctions or heart attacks. Stroke is stable, and we see a decrease in hypoglycemia, but an increase in hyperglycemia. So more people are developing high levels of glucose over time, but less people are developing lower levels of glucose over time. And there's a slight increase also in lower extremity amputations, which seems bad, but we think that's probably a good news story because major saving bigger limbs, key limbs, by having smaller amputations. So that's at the cost of major amputations. So we think that's probably a marker of success of medical care amongst people with type 2 diabetes. And now for the cost of diabetes. So these data have just been recently released by the International Diabetes Federation Atlas, and it shows that the diabetes costs the Australian health system over $9.1 billion annually, and that means that it's about $6,000 per year for each person living with diagnosed diabetes. Now, the previous estimates were, a third of that at $3.4 billion. And these estimates include costs due to type 2 diabetes, but also type 1 and gestational diabetes. And it also includes indirect costs due to lost wages and welfare payments. So diabetes is certainly a very expensive condition for Australia and will continue to be. And the other problem is that healthcare costs in developed countries like Australia are not cheap, and they seem to be increasing. Technology is in fact expensive. So in summary, diabetes burden in Australia is substantial, and our levels are consistent with other high-income countries. Now, as other countries also find, in Australia, burden is higher in those from disadvantaged groups, and in particular in First Nation Australians. Diabetes is expensive and costs greater than $9 billion annually in Australia. In Australia, diabetes incidence is slowing in the general population and may even be decreasing, although we're not seeing this in all population groups. And lastly, a good news story about diabetes is that the incidence of some of the traditional complications of diabetes, such as heart attacks and strokes, are now starting to decline in Australia.
Thank you, Diana. The management of type 1 diabetes has advanced rapidly through the development of improved methods for delivering insulin. To tell us more about the quality use of medicines in people living with type 1 diabetes, we'll now have distinguished Professor Dave Simmons joining us.
Hello, I'm Professor Simmons, and I'm delighted to be able to present to you at the National Medicine Symposium. I've got no relevant disclosures. What I'd like to cover today is the principles of insulin management, hypoglycemia, avoiding hypoglycemia and hyperglycemia, and some emerging issues. And we all know about the life-saving and life-changing discovery of insulin and how it allowed so many people to survive. The initial management of insulin was with quick-acting insulins, but this changed when long-acting insulins were introduced, and there was more concern over hypoglycemia than long-term complications. To manage the insulin,
people were on a fixed insulin, fixed carbohydrate regimen, and with a diabetic diet. And to make it easy for people with diabetes, increasingly people were using long-acting insulins, and mixed insulins were introduced as well. In 1993, the publication of the Diabetes Control and Complications Trial showed that running with an HbA1c of 7% meant that you had less complications, such as retinopathy, than if you were running, for example, at an average of 9% HbA1c. But with this improved glucose came an increased rate of severe hypoglycemia. And it was Professor Michael Berger who, at this time, had been introducing the fact that type 1 diabetes is a disease of insulin deficiency, and that the treatment of type 1 diabetes is insulin replacement and changing the insulin and not the diet. So the principles of this are to basically think like a pancreas. So you can see here that insulin goes up with each meal and that there is a background amount of insulin. So first of all, one has to replace the background so that there's some insulin there at all times, and that would be called the basal or background insulin. And then you need a bolus insulin to cover those meal times. And then after Michael Berger, we introduced the insulin to carbohydrate ratio, meaning we can change the amount of insulin as the carbohydrate changes. It was clear that some people needed less insulin during the day, for example, if they're very energetic. And therefore we were able to introduce shorter acting insulins being given twice a day, so you could have less amount in the day than overnight. And a way of dealing with that was a new invention, the insulin pump. Obviously things have advanced since then. However, this was not perfect. You can see how there was a mismatch between the insulin delivered and the amount needed, and that could lead to hypoglycemia and weight gain. It was very hard to hit those peaks of glucose. There was a mismatch. And then the carbohydrate type would vary and the amount would vary, and one had to be precise on that. And so sometimes the glucose would be high, so that a correction was needed, and then an insulin sensitivity factor was introduced, and that would need a glucose target that you would try to go down to with that ratio. And the background insulin actually varied a lot between people, not just with exercise, but just overall. So some people, if they didn't have enough background overnight, it would of course go up. But some people, perhaps if they're very energetic during the day, they'd have a hypoglycemic event at the night called the Somogyi effect. And some people have the dawn phenomenon, where due to those hormones that oppose insulin, they would have a glucose going up at 4 o'clock, and that person would have to inject a small amount of insulin at 4 o'clock, always afraid that giving too much would give hypoglycemia. And hypoglycemia is a horrible thing. They disrupt everyday activities. They provoke unpleasant symptoms. They can lead to severe hypoglycemia, causing coma, seizures, strokes, arrhythmias, and even death. And they have a negative effects on mood and emotion. They can impair cognitive function. They can lead to falls, crashes when driving, and they have their long-term effects, including that weight gain. And so the first other medicine introduced was, of course, glucagon. So to treat hypoglycemia quickly, and therefore the family and others around would need to be taught how to inject that glucagon, because the person concerned would not be in control. And then other ways to avoid this would be to have structured education for hypoglycemia prevention during the treatment. And then observation. If there are a number of hypoglycemic episodes, then clearly the dosage of insulin, the way it was given, needed to change. And over time, the technology has changed from that insulin pump to what we have now with automated insulin delivery, or AID. But of course, those cost. And the only plug that I'll put in this talk today is the fact that so many people with type 1 diabetes, now the majority, do not have access to automated insulin delivery. So we're very much fighting for this equitable access to diabetes technology. So how else can we deal with avoiding hypoglycemia and hyperglycemia? If you think about it, if it weren't for hypoglycemia, we could give as much insulin as we like, and then we could control this. But we need to manage that hypoglycemia. So number one is, what about a better insulin regimen? And there have been a number of insulins introduced in yellow, the quick acting, and then the medium acting, down to the long acting, yellow and green. Some of these insulins, they would have a dip. They're not flat acting. and they would have increased the chance of hypoglycemia. So we avoid those, and of course we avoid those pre-mixed insulins which have the problem of a fixed amount of quick-acting, for example. Also, for some people, clearly once-a-day insulin will not help if they need less during the day because of activity or if they have that dawn phenomenon. And we do have now, at the moment, the Levemir insulin, which is shorter than the 24 hours of the Lantus U300 or the Lantus U100, the Degludec, which has just been approved, and perhaps we'll get Icodec as well, which is a 7 days a week insulin. But some people do need different amounts day and night. In addition, that quick-acting insulin doesn't come in straight away. It takes 10, 15, 20 minutes. So people have to pre-bolus, and people are very busy, and often they don't. So the glucose goes up before it goes down, increasing that risk of long-term complications. So ultra-rapid insulins have been introduced. One is Fiasp, the ultra-fast Aspart, which takes about 5 minutes off the action. And the other one is Lyumjev, ultra-fast Lyspro, takes about 11 minutes off. As you can see, lots and lots of different insulins, lots of different pens. We've introduced pens because it makes it easy for a person. They don't have to pull up and syringe. They just basically click and point. Some people are so sensitive to the insulin that you have to calculate the amount of insulin they need to the nearest half unit. So we have half unit pens as well, for example, the EcoPen. Another thing influencing the action of that insulin are the injection sites. So the absorption can be affected by needle length, by the technique, and also by trauma into the area. So we have to be very careful, and we need to protect those very precious insulin sites to make sure that they don't get what's called lipohypertrophy. And one of the ways we do that is to change the number of times the insulin needle is used, for example. You can see here on the right that a pristine insulin needle is really sharp, goes in, comes out. Even after one jab, it's like a harpoon. You can see it goes in, and that very tip will rip out some of the flesh and increasingly damage that skin, so you end up on perhaps something like this, where there's things even larger than golf balls. If you inject into lipohypertrophy, it takes a long time for that insulin to be absorbed and to act, and that changes the game. And you can imagine, you inject at the end or don't inject to it, absorption is one thing. If you inject into the middle, it takes a lot longer. How do you avoid that hypo and hyperglycemia if you can't predict the insulin action? So one of the ways that we can do this is by using technology. And we have 4 main areas in which we use technology. One is the insulin delivery. One is by glucose sensing for that target and letting the person know what's going on. So the correction factor needs a target. Another one is with data management, where you can share the data and also you can calculate that insulin to carbohydrate ratio. And then the automated approaches, which I'll get onto shortly. So there are 3 main glucose sensors, continuous glucose sensors in Australia. One's the Dexcom G7, just replacing the Dexcom G6, the Libre 2, and also the Guardian 4 by Medtronic. And these allow the glucose to be known every second of the day, every minute of the day. However, they're not perfect, and sometimes they can read too low or too high, particularly as they measure the glucose in the interstitial fluid. So sometimes a finger prick test needs to be done to show what the glucose really is in the blood. But they do give so much by having 24 hours of data. And you can see here an example of an ambulatory glucose profile. You can see what proportion of the glucoses are in the target range. So the green is time in range. That's supposed to be 70%, between 3.9 and 10 millimoles per litre. Slightly high is yellow, very high is orange, and then you've got the reds below, which are hypos. And you can see the pattern. Where should we put the extra insulin, for example, or where we need to change what we do? You can see that peak at around breakfast time, and it can give you the day-by-day changes to say, is this something that's consistent or something that only happened because of a party? And then to help with those calculations of that bolus, many people are not very good with numbers. They think that they are, and they calculate in their head, and they can be wrong. So the majority of patients either do not correct for high glucose or get the calculations wrong. So these meters have the glucose, and they're programmed with an insulin to carb ratio and correction factor. And it can advise the person how much insulin to give. It gives the amount to cover the food, that's the bolus, and then it adds the correction if it's high. And that's the total amount. And studies have shown that this is associated with improved HbA1c, reduced hypos, and improved quality of life. We also have smart insulin pens that can link to the glucose meter and also record the insulin that's being used and can also give those calculations. And they allow the data that comes from that to be shared with healthcare professionals or with family or with others. But really, one of the best ways of doing this is with an insulin pump. Continuous subcutaneous insulin infusion allows more physiological replacement of basal insulin requirements. They can change hour by hour. And there's lower variability of absorption of basal insulin. It's given in very small amounts. The larger the bolus, the longer it takes to be absorbed. So giving it slowly is really much more precise. And it also allows on-demand modulation of how much insulin is given. Once you've given your Lantus, for example, once you've given your Glargine, it works the whole day. What about if all of a sudden you're really active? That's very difficult. With a pump, you can change that straight away and say, oh, I'm going to give myself a temporary rate of half. So if there's stress and the glucose is going up, again, you can temporarily put that glucose up. And then when you link with continuous glucose monitoring, there's something called predictive low glucose suspend technology. So there, the glucose tells the pump, hey, look, this person's heading for a low, stop the pump. That's mainly been replaced now by these automated insulin technology approaches. And another thing to help people is some people do not like being seen with the pump and they don't like the tubes that are attached. They also perhaps are doing a job where the tubes get in the way. So on the right you can see patch pumps where they're linked by Bluetooth to the controller set and they can they're basically a pump but they have no tubing and they get thrown away after a period of time after the insulin is used. One of the issues around pumps is that we can't use that ultra-fast acting insulin, FIASP, because it can crystallize, which for a small number of individuals that can impact on their glucose management. So what about these automated insulin approaches? So these are also called closed loop. So here's the sensor, it's picked up, and then by Bluetooth, it's linked to the pump. And it says to the pump, this is the glucose. The pump then uses an algorithm and says, this is the glucose, this is the amount of insulin we should be giving, both in the basal, but also as the bolus and the correction. This is how much it should be given. And so it's an autonomous, graduated modulation of insulin delivery to achieve that target glucose. Meal boluses are still required. Some do bring the glucose down quite well within 2 or 3 hours, but if you want to have as much the glucose within the target range as you can, then you really want to pre-bolus and you also want to make sure that you cover those meals. And with these in the randomized trials, we get at least an increase in time in range of 12% and a reduction in HbA1c of 0.5% or more. And that's reduction in complications in type 1 diabetes of about 20%. So this is a major advance and has shown to be and makes people with type 1 diabetes much more independent. So these are the systems that are available today. Here's the Tandem, and this is the old G6 sensor. Here's the MiniMed 780G with the Guardian 4 sensor. And over here is the Ypsomed pump, which uses a CAMAPS algorithm. And that talks here to the Dexcom G6, but can be the Dexcom G7. And those are examples. They all have their pros and cons, but they all are associated with improved time in range and reduced HbA1c, improvements in hypoglycemia, and a better quality of life. Now, there are some people, these pumps are $8,000 to $10,000, and people can't afford them unless they have gold level insurance. But there are those who say, look, I've got this old pump, I've got this old sensor, I'm pretty good with the technology, and they're called loopers. They make their own algorithms, and there's quite a lot of them on the web. They're not covered by the TGA and others, and sometimes we have concern, what happens if they break, how do we give advice? But these are around, and they can be of benefit as well. One of the other key barriers is, does the person with type 1 diabetes know how to manage their insulin? And are there barriers to them self-managing? So, there is no other condition that demands more of the individual than type 1 diabetes. It requires lifelong changes. It requires minute by minute control, and it really is a heavy burden to that person's family and the healthcare system. And current treatment is either those multiple daily injections or with insulin pump therapy, but it still requires either the sensor or multiple finger pricks, carbohydrate counting, and being dynamic with these adjustments according to what's happening in life. Many have what's called poor control, and I'm going to come back to that terminology. Their glycemic variability frustrates them. If every time you do something it doesn't work, then people usually give up, and people can be depressed, they can be anxious, and they're just really, they lose motivation to do things. In addition, if you have multiple hypos, then you lose the sensitivity to that. And impaired awareness of hypoglycemia affects 20 to 40% of people with type 1 diabetes, and some of that can be severe hypoglycemia where they are unconscious or have lost control and their life is in danger. So this is the threat that they're living under, and we really need them to be as motivated as we can. Can you really think of doing that for 50, 60, 70 years? And one of the things that demotivates is that, for example, that term, glycemic control. Glycemic control to some people implies, you've got poor control and you're not controlling it. And that language used by health professionals can have a profound impact on the person living with diabetes. And here's just a couple of quotes about how demotivating it can be and how angry they can be by being blamed for something which, for so many reasons, it's out of their control. So besides the physiology, which is a major barrier to us, and our imperfect technology, including our insulins, there's this variable insulin absorption and problems with insulin injection sites. Then people, if they've had multiple hypoglycemia, even after one, it's something that can create fear and needs things like CBT to address. There can be needle phobia, and there can be diabulimia, where people use that glucose, high glucose, so that they don't put on weight. Very much like anorexia. And there's this relentless burden, the depression, the anxiety, lack of motivation. Is it surprising that some people do not want to see and do not want to monitor their glucose because they feel that they can do so little about it? And then it's us as well as health professionals. Sometimes we don't act as quickly as we should, so that's clinical inertia. And then, of course, if the person doesn't have access to the technology, like the insulin pump, or to the healthcare professional, again, these are major barriers. And if they've not received or not engaged with quality structural education, then their self-management skills are not necessarily as good as they could be. And here's a list of 42 factors that affect the blood glucose. Can you imagine if you had all 42 in one day? Well, it can happen. So those self-management skills, they're absolutely crucial. And most people learn them bit by bit. So there aren't that many really structured programs around with evidence. And the only one with randomized trial evidence is OSDAPHNE, or DAPHNE, Dose Adjustment for Normal Eating. This is a 5-day group program for 6 to 8 adults with type 1 diabetes using insulin pens or OSDAPHNE pump with pumps. And it can be either through the week or 1 day a week for 5 weeks. And it's a structured, comprehensive self-management education, allowing people to learn how to adjust and assess their insulin needs, counting carbohydrates, managing those barriers and hypoglycemia, physical activity, alcohol that can put the glucose down, and eating out, and sick day rules, and other things as well. It's run by a credentialed, specially trained OSDAPHNE diabetes educator with a dietitian, and they work together with a team with those 6 to 8 people who have a lot of knowledge of their experience with diabetes, perhaps over 50 to 60 years. And then they have a follow-up at 6 weeks, 6 months to 12 months to check that the things are, that the management is going well. And the randomized trial, the H1C was lowered by 0.4%. The risk of DKA, diabetic ketoacidosis, was reduced by 61%. The risk of severe hypoglycemia reduced by 72%. Anxiety and depression were reduced to background. The quality of life and treatment satisfaction were increased. And the insulin doses actually came down, sometimes up to 30%, because they were being tailored. The person had learned to tailor them to their life. And the need for insulin pumps went down, and the cost went down by 64%. This really is a wonderful intervention, but it only has limited availability in Australia. So some of the emerging issues in type 1 diabetes are the processes by which type 1 diabetes developed. We now know that most will be type 1A, which is T-cell mediated, it's autoimmune. It goes through stages as those beta cells into production increasingly is reduced. So people go through stage 1 where insulin production is reduced but the glucose is okay. Stage 2 where the insulin production is reduced, they've got these antibodies but glucose is up a little bit, and then either diabetic ketoacidosis, or that can be avoided if people know that they're heading for these very high glucoses. And can we now intervene? Well, we're just starting to bring in these disease-modifying agents in type 1 diabetes. So a couple of years ago, teplizumab in the United States was approved for use in type 1 diabetes. The median delay is around 12 months, but for some people it's obviously longer. You can see here perhaps up to 5 years. So these are now being brought in, and it's important that people understand that increasingly we know what to do, and we will slowly bring these drugs in as they're more effective and resourced. Another event which is coming is the loss of the only flat insulin, which is twice a day, the loss of Levemir when we have no pumps. In Australia, most people don't have pumps. It's going to be gone in December 2026. It's a global strategy by the company. And yet we know from at least this observational data that twice a day insulin is better than once a day, and Levemir is the best insulin to do that. So in some individuals, moving them from to the once a day insulin from twice a day Levemir, when they needed different day and night doses, they've got a choice. They either give more insulin in the day to keep the nighttime glucose under control, they will have hypos and perhaps life-threatening hypos, or they'll take less insulin at night. They have hypoglycemia and they're at risk of future complications. A further emerging issue is obesity in the population, but also in adults with type 1 diabetes. And remember, there's this mismatch between insulin and the food that's eaten and its absorption. So with hypoglycemia, very easy to put on weight. So in 1985 to 90, the prevalence of obesity was 3.3% in adults with type 1 diabetes. 2015 to 2020, 22%, a massive increase. And with obesity comes insulin resistance. And then there's this, it's kind of a colloquial term, double diabetes. It's not official, but many people will use it. It's when you've got both this insulin secretory deficit, where you can't make insulin in most cases, and in association, there's the insulin resistance, which means you need more and more insulin, which also means, of course, that it takes longer and longer to absorb it, and you may lose that acute, quick-acting effect. Are there ways to address that insulin resistance? Well, people have tried metformin, which is quite helpful, 19 randomized trials that can at least be associated with a reduction in the weight by about 2 kilos. And in some individuals, it does make that insulin more sensitive and it does help their self-management. People have tried SGLT2 inhibitors, and yes, they're associated with a small decrease in HbA1c and also in weight, but there is also a risk of diabetic ketoacidosis by the way that they work. So we just have to be cautious with those if we are going to use them, but they're still not used very much because of that concern over diabetic ketoacidosis. As we all know, the GLP-1 receptor agonists are everywhere, and that includes something which may be used by people with type 1 diabetes. And so for the early GLP-1s, you can see in this meta-analysis that the total daily insulin needs were down by about 5 units, and also the weight was down by around 4 kilograms. So they are effective and they can be used. And now we have more effective GLP-1s, and this time with GIPs, and this one is tirzepatide. And this is an observational study, but what it shows is that 8 to 10 kilo weight loss, a significant reduction in HbA1c, improvement in time in range of about 10%, and overall really an improvement in management with the GLP-1 GIP agonist. So perhaps this will be something which again people will ask you for, but of course it's not approved in type 1 diabetes, it's approved for management in type 2 diabetes at the moment. So just to conclude, type 1 diabetes requires insulin treatment. It has 3 jobs: the background, covering food, bringing the glucose down if it's high. The unpredictability of glucose with this makes life hard. Hypoglycemia remains a key barrier to achieving near normal glucose levels. Self-management skills are crucial. They bring empowerment and they bring hope. And OSDAFNI has randomized controlled trial evidence of benefit. Much development in insulins and devices has occurred to help self-management and management overall. The ability to monitor glucose continuously with no or limited finger pricks has been life-changing for so many people. Everybody with type 1 diabetes has access to CGM technology through the NDSS, which we're very grateful for. The automated or closed-loop insulin delivery is now a reality. It works well, and this pump access is available in many high-income countries, but sadly not in Australia. And there are some emerging issues. Type 1 diabetes prevention is now slowly entering the world of reality. Obesity is a major impact on our quality use of insulin, and the loss of Levemir potentially will impact on management of a number of people with type 1 diabetes. I'd like to thank my colleagues, my credentialed diabetes educators, Kathy Wilson and Therese Fletcher, and also Lala Leelaratne for the slides. Thank you.
Thank you, David. Now let's learn about the quality use of medicines in people living with type 2 diabetes, including the effects of diabetes medicines beyond glucose control, with Professor Jonathan Shaw.
Well, thank you very much for inviting me to take part in this meeting. I'm Jonathan Shaw from the Baker Heart and Diabetes Institute in Melbourne. I'm an endocrinologist, and what we'll talk about in the next 20 minutes or so is the management of type 2 diabetes as it relates to medication. Here are some disclosures just before we start. We use medicines for a number of different things in the management of type 2 diabetes. And probably the best categorization of that is we use them for glucose lowering, since diabetes is obviously a condition in which there is elevated glucose. Many people with diabetes also have elevated blood pressure, and so that's a common use of medicines. And we frequently want to reduce the lipids, particularly the LDL cholesterol, and so LDL lowering and lipid lowering is a key component. Beyond that, lifestyle is important for all of these outcomes. And it's also important to bear in mind that many people require multiple medications in order to manage certainly glucose lowering and blood pressure lowering. So let's focus mainly on glucose lowering and start by asking, what are the aims? It sounds perhaps a little foolish, since it looks like the aim must be to lower glucose, but there is a little bit more to it than simply lowering glucose. The reason for that comes from an understanding of the complications of diabetes. Now, there are many complications of diabetes, but the classical traditional ones are the ones that drive the way in which we manage and treat people with diabetes. On the left, we have the so-called microvascular complications. This is eye disease, kidney disease, nerve disease. These are essentially pathognomonic or absolutely typical of diabetes, and they essentially arise because of increased exposure to hyperglycemia, too much blood sugar. And for that reason, when glucose is lowered and starts to get towards normal ranges, we see a major impact of such treatments on the risk of those complications. And if you could normalize blood glucose, you would effectively get rid of those complications. But we also have another group of complications, the so-called macrovascular complications. This is like MI, heart attack, or stroke, or peripheral artery disease. Now, these are not pathognomonic of diabetes. Anybody can get those. Their risk is increased in people with diabetes, but there are many other risk factors that are relevant, and improving blood sugar control, good glycemic control, has at best a modest benefit on preventing those. And so that needs to be borne in mind as we think about the treatment of diabetes. So as a result of this understanding that there is more to preventing the complications of diabetes than just lowering blood glucose, an approach that focuses just on lowering glucose will not be enough to prevent all of the complications of diabetes. So here we can see an analysis of the various different options that we have for treating type 2 diabetes, for the different medicines that are available apart from insulin. A nice paper published last year showing how this has changed over the last 10 years. And so you can see, if you look at the graph on the left, the usage of these different drugs. So we have metformin, which by most guidelines, the most widely used being the RACGP and the Australian Diabetes Society guidelines. Metformin would usually be the first line drug, and not surprisingly, that means that it is the most widely used and has actually increased over the decade that is reported here. Beyond that, we have DPP-4 inhibitors and GLP-1 receptor agonists as other options, along with acarbose, sulfonylureas, and SGLT2 inhibitors and glitazones. All of these are covered in the guidelines. As you can see there, over this time period, the use of DPP-4 inhibitors increased, but somewhat then plateaued, and there has been a reduction in the use of sulfonylureas, partly because they cause weight gain and hypoglycemia, and as we have increasingly been aware of and had available different options, they have been used instead. But the most important thing to see on this slide is the increasing rates of use in the black and in the blue for the SGLT2 inhibitors and the GLP-1 receptor agonists, which became available predominantly during this time period and have become very widely used drugs, somewhat displacing some of the others. Interestingly, when we look at the right-hand side of the slide, we can see the implications of this for cost. Whilst the patterns are broadly similar, we now see that metformin, as a rather old and therefore cheap drug, has fallen down from being the most widely used to being just average in terms of its total cost to the PBS, whilst GLP-1 receptor agonists and to a lesser extent SGLT2 inhibitors become the most expensive and the drugs that are accounting for the largest proportion of PBS funding allocated to or used in type 2 diabetes. So this is very clearly an indication of the changes that we have seen within the guidelines that we have available for the use of these different agents and its impact both on use and on cost. Those are the options that we have, and those options lead to a number of issues, and they're detailed here. So first of all, the fact that there are multiple options is on the one hand a good thing, lots of different ways to find perhaps what is the right or the better drug for an individual person. But on the other hand, it means that for people who are not entirely embedded in the field, and that's where most of type 2 diabetes is managed in primary care, it's hard to keep up with all the advances, all the changes, and all the regulatory rules that go along with that. Since none of these drugs are on their own typically enough to control diabetes in large numbers of people, there is often the need for polypharmacy, even just for the issue of maintaining adequate glucose control. And so this raises this kind of a tension between, on the one hand, wanting to have used all the drugs that will deliver benefits in different ways, in other words, treating someone adequately, versus trying to minimize polypharmacy and all the issues that go along with polypharmacy, of which, as we know, adherence, which is the next bullet point, is an important part. And in general, the more prescriptions, the more different drugs that we ask a person to take, the smaller proportion of each drug they will likely actually use. We then have to think about these issues about glucose lowering versus impact on clinical outcomes, and they're not the same thing, as I've alluded to and as we're going to see in a moment. In other words, as a practitioner managing this, one has to think not only about are you getting adequate glucose lowering, but are you using drugs that we know will have impacts on the important outcomes. And finally, we've got some of the more administrative and regulatory issues about cost, both to individuals and to society, essentially through Medicare, and the complexity of reimbursement through PBS, which is complex for people who aren't using these drugs day in, day out. So let's now focus on two of the categories that we have: the SGLT2 inhibitors and the GLP-1 receptor agonists. And these are the newest additions to the canon of drugs that we have available for managing type 2 diabetes. So the SGLT2 inhibitors work in the kidney. They reduce the amount of glucose that is reabsorbed, and therefore more glucose is excreted. Nobody really expected that making you essentially excrete glucose through the urine would lead to any benefits other than lowering glucose and perhaps losing weight. But when we saw the first major outcomes trial for one of these drugs, the EMPA-REG trial, and all new diabetes drugs for the last 15 years have had to have a large cardiovascular outcome trial, essentially to ensure safety of the drug. When we saw the first of these report, the EMPA-REG trial, we saw not only that empagliflozin, an SGLT2 inhibitor, was safe from a cardiovascular perspective, but that it actually, and very differently to other drugs that had been previously tested through these means, had quite marked benefits in terms of these cardiovascular and renal outcomes. 3-point MACE, which is a combination of non-fatal heart attack, non-fatal stroke, and fatal cardiovascular disease, was reduced by 14%. Heart failure was reduced by 35%. Kidney disease was reduced by 39%, and total mortality, perhaps the best test of any intervention, was reduced by 32%. Now, these were quite extraordinary findings when they first came out 10 years ago. Fortunately, most, though not all of these, have been seen in subsequent trials. And what you see on this next slide is a summary of the effects of these agents, and not just empagliflozin, but other SGLT2 inhibitors in similar populations of people with type 2 diabetes. And clearly the most consistent and most effective outcome for these drugs is on heart failure and on kidney or renal outcomes. And trial after trial shows something like a 30 to 35% reduction in the risk of heart failure and a similar reduction in the risk of kidney disease for people treated with these agents compared to those treated with placebo. And this is really where the strength of these drugs lies. So much so that, in fact, they have now been trialed in people who don't have diabetes. And this interestingly gives us a nice insight into the way in which they might have been working in people with diabetes. So here is a trial of an SGLT2 inhibitor, dapagliflozin, in people with chronic kidney disease, looking at the effect of this on progression of kidney disease. Is a mixed population. Again, we see the same sort of benefit, a 39% reduction in this outcome. When we start to look at the different groups of people within the trial, we see, as with many trials, that the effects are rather similar with different subgroups. In particular, we can focus on those people who did and those people who didn't have diabetes. And these confidence intervals overlap, which means that the effect of dapagliflozin was effectively the same in people with and without diabetes, indicating that lowering glucose is very unlikely to be an important part of the mechanism of these drugs. There's been a similar set of trials in heart failure. This is with the other SGLT2 inhibitor, empagliflozin, a mixed population of people with heart failure, some with diabetes, some without, a 25% reduction in the risk of heart failure. And once again, we see that the effect of empagliflozin was almost identical on those people with and those people without diabetes. Once more, strengthening this idea that the effect of empagliflozin on these outcomes in people with diabetes is not really due to its glucose lowering. And this becomes important in understanding how we will use these drugs. So much so have this class been deemed to be effective and useful that in the most recent update of major guidelines internationally, and this is a draft guideline that's come out of the UK from NICE, we see that for most groups of people, NICE in this draft guideline is recommending that initial therapy of type 2 diabetes is a combination of metformin with an SGLT2 inhibitor. This is now in this draft guideline, no longer a good second or third alternative, but something that should be offered to everybody when pharmacotherapy is initiated. Let's quickly look at the other major new kid on the block, as it were, GLP-1 receptor agonist. GLP-1 is a natural gut hormone with a wide range of effects on gut function, on brain, and on the pancreas, and on a number of other areas. We're not going to look through the trials here individually, but we'll go straight to a meta-analysis of several trials in people with diabetes, showing that for each of these important outcomes, MACE, that's non-fatal MI, non-fatal stroke, cardiovascular death on its own, MI or stroke on its own, that there is a modest but definite benefit for GLP-1 receptor agonists. And similarly, when we look a little bit further afield, all-cause mortality, heart failure hospitalization, and probably for kidney disease, once more seeing benefits. There has actually now been a dedicated kidney trial for semaglutide, one of these agents in people with kidney disease, showing very clear benefits. And in fact, we're also seeing, though there's a lot less data on this to date, benefits outside the population with diabetes. This is semaglutide in a population with obesity and established cardiovascular disease, and the primary cardiovascular MACE outcome was reduced by 20%. Once again, showing that now for this drug, that there doesn't appear to be a major role of glucose lowering in leading to the benefits that we are seeing for these important outcomes. We've also started to see some benefits for semaglutide in people with peripheral artery disease, improving walking distance. One of the reasons for showing this is that there is a concern that drugs like this, which cause weight loss as well as improvements in blood glucose and reductions in cardiovascular risk, might have an adverse effect on muscle function. This group of people was able to walk a little bit further when they were on semaglutide than people who were treated with placebo. And along those lines, there have also been concerns that weight loss may not be a good idea for elderly people. So this is a meta-analysis of trials looking at the elderly populations. The elderly populations were generally rather small, but when you put them all together, it seemed that those people who were over 75 in the randomized controlled trials got pretty much the same benefits as did the younger people. So the benefits of these drugs are unlikely to be heavily due to glucose lowering and seem to be apparent for the elderly as well as younger people. So let's now think about how we put this together. And certainly this is where it gets complicated for people who are not in this field all the time. So on the left, we see TGA indications. In the middle and on the right, we see PBS issues. So we have TGA indications for GLP-1s, both for diabetes and for semaglutide in the form of Wegovy for weight management in people who don't have diabetes. But PBS, at least at this stage, is only there as an option for people with diabetes, and then only if people have inadequate blood glucose control. So it's not a risk-based analysis based on whether or not someone has high risk of cardiovascular disease or renal disease. It's for PBS, it's there as a glucose-lowering agent. Now, the SGLT2 inhibitors, a little bit broader, they certainly have that glucose-lowering indication. There is now an indication to use them in people with diabetes and high cardiovascular risk, irrespective of their level of glycemia. And outside diabetes, we can use them for people with renal disease and for people with heart failure. But it's clear that there is a degree of complexity to this that is not easy for everyone to deal with. So how should we be thinking about these things? Well, ideally, we should be assessing people with diabetes first on their risk, not first on their blood glucose control, but first on their risk. If they are at elevated cardiovascular or renal risk, we really should be thinking about either an SGLT2 inhibitor or a GLP-1, irrespective of their glycemic control or HbA1c. And that, as I indicated, is at least partially supported by PBS. Once we think more broadly about pure glucose lowering, most of the options have a potential role. There is an advantage to those that don't lead to hypoglycemia, low blood glucose, and probably an advantage to those that don't lead to weight gain. What might happen in the future? Well, I think that we will know more about the benefits of SGLT2 inhibitors and GLP-1 receptor agonists, particularly in the realm of liver disease and in cognitive function. We're still learning about some of the side effects and potential harms, particularly for GLP-1s in relation to eye complications and muscle loss. We are going to get oral versions of GLP-1s. The current ones are injectables. There are oral versions in advanced stages of testing. And we may well be getting drugs that will preserve muscle function, even though there is weight loss. And I think more broadly, in terms of the future of medicine's management of type 2 diabetes, we may well be seeing more of the sort of type 1 diabetes type technology, continuous glucose monitoring, and insulin pumps. So in summary, we certainly have multiple options for drug management of type 2 diabetes. If we lower blood glucose by any means, we're going to lower the risk of microvascular disease, but SGLT2 inhibitors and GLP-1 receptor agonists offer further benefit, at least for kidney and cardiovascular disease, through non-glucose mechanisms. And really, we should now be thinking of those agents, SGLT2 inhibitors and GLP-1s, to be used based on risk of cardiovascular or renal disease and not just based on glycemic control. And here you can see some links to some of the resources that I mentioned, in particular the guidelines that are most widely used, and these will also be made available to you outside of this presentation. And with that, I thank you very much.
Thank you, Jonathan. Coming up next, we're going to explore further the management of diabetes medicines in primary care and find out how integrated models of care can improve diabetes management. So stay tuned and see you after a short break. Thank you to everyone who is joining us today from around Australia. Welcome back. Let's head straight back into the program by hearing from Professor Stephen Twigg on the use of medicines in people with diabetes, particularly those with or at risk of complications.
Hello, my name's Professor Stephen Twigg. I'm from Royal Prince Alfred Hospital and the University of Sydney. It's a pleasure to be presenting on this topic of the complications of diabetes at the National Medicine Symposium 2025. I've been given quite a broad agenda and I shall do my best to stick to topic and time and hopefully impart some applied knowledge that might be helpful for our audience. I recognise the Gadigal people of the Eora Nation, which are on the lands of Royal Prince Alfred Hospital and vice versa, and also the University of Sydney and also where we're filming today. And elders past and present as the traditional custodians of the land and emerging into the future Aboriginal peoples. And as we know, in people with diabetes, there's a much higher rate of complications as well, so a particular high-risk priority group for management. I'm going to address in a somewhat ambitious agenda today the rational use of medicines in people with diabetes with the focus on complications, and then linking into that, not only going on from the rationale but the more specific aspects of consumer advice in use of such medicines, risk-benefit issues related to medicines in people with diabetes, complications, and then I'll move on to some practical adherence issues that hopefully will be useful in this space. That means I'll be addressing mainly the good, but also some of the bad and ugly challenges when it comes to medicines in diabetes complications. So why manage blood glucose in the first place? Well, there's three main rationales. One is to help prevent onset and worsening of diabetes complications. But there's also important issues related to acute management in the setting of sick day management or emergency presentations. And our audience should keep in mind as well that palliating against symptoms of hypoglycemia is also very important. So what do I mean by that? For example, a person in institutionalised care with diabetes in a nursing home, if they have high glucose levels, it can cause incontinence of urine, urinary tract infections, pressure sores. Whereas if the glucose levels are better managed, those symptoms can be largely managed in an appropriate way. I don't have time to discuss palliation of symptoms further, nor the acute presentation, but to flag that these issues are important. Sometimes patients need to be referred to the emergency department, particularly if they're looking unwell, if they have very high glucose levels and/or high ketones in their blood or urine. But I am going to focus mainly on end organ complications of diabetes today, which is what most people will think about in this topic. And so diabetes mellitus is a condition where the pancreas essentially is not making enough insulin to manage glucose levels. Insulin acts like a key to help glucose get into cells to then generate energy for the body to function. And as we know, this standard linear pathway is the most common one in people who develop type 2 diabetes, and also the other condition of type 1 diabetes, whether it's an immune insult on the pancreas or whether it's related to genetic susceptibility with body weight issues and more sedentary lifestyle. Ultimately, if a person's pancreas is unable to respond, glucose levels will become elevated into the range of diabetes, and this will contribute inevitably to some degree of cell and tissue injury. And in terms of diabetes complications, at any one time, about 5 to 10% of people have quite severe end organ complications of diabetes and towards the more severe stage. But with time, most people with diabetes will develop some complications, and our plan is to try and help prevent, stabilise and even reverse those complications if we can. And medicines have an important role to play in that space. Some years ago, Professor Gensio Wong and I in the Medical Journal of Australia identified diabetes complications as having a broad spectrum. And on the top line are the standard micro and macrovascular complications, the micro involving the eyes, the kidneys, to a degree the feet with neuropathy, macrovascular, cerebrovascular, cardiovascular, and to a degree peripheral arterial disease. But there's also the hypoglycemia one there shown on the top left related to therapy depending upon the medicine used. In addition are the diabetes-related ones which are exacerbated often by people, for example, with type 2 diabetes. The conditions are more common and or more severe. And I've shown there's some infectious ones, periodontal disease, for example, as well as an inflammatory disorder, sleep apnea, and also I'll come back to fatty liver disease and more severe forms of that. So we need to consider the broad spectrum these days of diabetes-related complications, and diabetes is the commonest condition linking into comorbidities than any chronic condition. So most people with diabetes will have multiple other diabetes-associated complications and other comorbidities, for example, sleep apnea, if they have type 2 diabetes. Diabetes globally is recognised to be the 4th commonest cause of disability of any condition, and as can be seen here from the Australian Institutes of Health and Welfare, it has progressively taken over, contributing to disability with a measure known as DALYs, and the reason for that is that the number of people affected, even though people are living longer with their diabetes, complications are still common, and then the absolute number is creating a significant burden, as can be seen on this graph. Well, we have a lot of ways to intervene which complement each other in people with diabetes: nutrition, exercise, medicines, and sometimes even surgery, for example, metabolic surgery. Medicines, of course, can be oral, injectable, and there's the very important function of developing rapport with the person with diabetes and their carers, if relevant, and we have multidisciplinary teams. I've shown in the middle there some of our diabetes educators and nutritionists through our diabetes centre. So it's not purely the traditional medical model, it's an entire team getting to understand the person who has diabetes and what might work best for them, and counselling about options in therapy. In terms of a broad overview of diabetes and its complications, individualising glucose targets are important. We do have generic HbA1c and glucose-related targets, but then we can individualise from there, and there are a number of good national documents on that. Screening for diabetes complications can help us to detect the complications earlier and then change their natural history. We can use medicines as well in combination with lifestyle to help prevent the severe end organ complications, and medicines to help reduce the risk of acute on chronic complications. For example, cardiovascular disease, end-stage kidney disease, foot disease in diabetes, and also vision loss. Lipids and blood pressure are important, so we have to ensure that we're not purely glucose-centric. And for example, the bad cholesterol, the LDL, that's very important to reduce macrovascular event risk. And then also to be aware that there are specific needs of people that have the more severe later stage complications. For example, I'll mention shortly, in foot disease, if someone has a foot ulcer, that requires specific multidisciplinary care to treat it, help it heal, prevent amputation. And so if we consider from a glucose point of view, what is the evidence that targeting glucose can help prevent complications? We have good quality control studies showing that retinopathy onset and worsening, chronic kidney disease can be prevented to a degree in their progression, less so for neuropathy, and at this stage not for foot ulcer healing. Blood pressure and lipids, of course, being important as well, and we need to know our evidence base and individualise our glycemic care. In terms of diabetes complications screening, foot disease, eye disease and kidney disease, and if anyone is symptomatic of cardiovascular disease or there's a reason why they might need more objective testing for cardiovascular disease, then that should also be undertaken. And More recently has been the recognition, the Australian Diabetes Society with the Gastroenterology Society of Australia have described assessment for fatty liver disease known as MAFLD and the more severe form, especially that involving liver fibrosis or scarring known as MASH with fibrosis, that we need to undertake a two-step screening procedure, a clinical algorithm known as FIB-4, Fibrosis 4 Index, and then secondly, if a person does not have a low reading, then they need a further assessment, either a blood biomarker test or a test known as FibroScan transient elastography. And all that information has just in the last year become available in terms of position statements and guidelines, to which I'll refer you further, but worthwhile considering that in people with this condition known as MAFLD, dysmetabolic associated fatty liver disease, that it's on the far right there at the bottom where there's some blue changes, that's scarring in the liver, and that's the one as well which in particular is linked to worse prognosis, and if we can detect that early we can stabilise it and in some cases reverse it. This study in people with liver fibrosis using semaglutide demonstrated that at high dose we're able to stabilise and in some cases reverse the fibrosis that otherwise will occur in some people who have fatty liver with fibrosis known as MASH fibrosis. And again, I refer you to the guidelines in this area. From the point of view of cardiovascular heart outcomes, some years ago now, the class of agent known as SGLT2 inhibitors astounded the world, in particular empagliflozin in this study, demonstrating reduced mortality and also in particular heart failure in people who were at high risk of recurrent events. And the EMPA-REG study shown here, the key result showing that whether it be lower dose or higher dose empagliflozin, there was a reduction in this case of all-cause mortality. And this led to recognition, number needed to treat. Not only do we use cholesterol-lowering medicines such as statins, blood pressure managing medicines such as ACE inhibitors, commonly in people with diabetes to target the LDL cholesterol and blood pressure respectively, but now we use these agents, SGLT2 inhibitors and incretin mimetics as well, to in particular, not only improve glucose, but specifically help reduce cardiovascular and renal adverse outcomes. And the dapagliflozin study here, known as DAPA heart failure, following through from the EMPA-REG study, demonstrating similar outcomes in people in this case at increased risk of hospitalisation for heart failure with type 2 diabetes, and dapagliflozin did similarly well as per empagliflozin, showing that we have a class effect of those drugs. Now, I mentioned earlier from the feed point of view that we need to have an insurance process to make sure that people with diabetes have their feet checked, they get their socks off. Secondly, that we can help prevent ulcers and amputations at an individualised level. If ulcers do develop, then a person needs treatment at a specialist high-risk foot service ideally. So this is where we individualise our treatment as an example. Well, we've covered our first 2 points reasonably well, but moving on to specific medicines in diabetes complications, metformin also may reduce cardiovascular events. I've mentioned SGLT2 inhibitors and GLP-1 mimetics as agents that can be specifically useful. And the other medicines I've noted here can improve glucose levels, but haven't been shown to have the same specific preventive effect on cardiovascular and renal complications. Pioglitazone has been around for many years as an agent known as a TZD, and it's interesting, it's undertaking a resurgence. Here's a very detailed algorithm for glucose-lowering medicines from American Diabetes Association, but a particular change, this year's algorithm change, if you like, profile, has been on the bottom left there. If people have liver disease, and that should affect decision making about which medicines might be preferred. And I've shown you already the incretin mimetics have evidence compared with the SGLT2 inhibitors for severe liver fibrosis. So moving on to what do our consumers tell us in the diabetes complication space. They like medicine that can reduce weight, not cause an increase in weight, particularly if they're overweight. So pioglitazone causes weight gain, so that would generally be avoided. In contrast, incretin-mimetics and SGLT2 is more effective. Minimising hypoglycemia is important, and people with diabetes tell us that they fear these severe complications, and one of those coming into the fray that we need to learn more about is dementia. There are issues as well for the individual of equity of access and financial cost. So the last couple of minutes, going back to the overview of medicines for people with diabetes and their complications. One size can fit all in most cases. We can see from this slide here, we may not know the individual well, but if we take a systems approach, we can certainly help most people in their outcomes. But if we get to know the individual, we can more specifically target our therapies so that we can be more effective with respect to the individual patient needs. And if we move on to some practical adherence issues, unfortunately we know some of the newer agents that help with weight loss and are potent with improving glucose, that the adherence to those medicines as well is frustratingly lower than we would like, sometimes from side effects and sometimes maybe from human behaviour alone. Less than 70% adherence at 12 months for any of the medicines I've mentioned is usual. People, if they are clinically depressed, often adhere less well to taking their medicines, and in that setting, we used to think treating the depression will lead to sudden improvement in medication adherence, but it's clearly the case people need to relearn, if they have not been adherent to their medicines, that not only treat their depression but help them to follow through with their appropriate medication taking. Sometimes we find people will stop one medicine, such as a statin, and not their others. So we shouldn't presume, if they're taking their medicines generally, that they're taking all of them. And in our diabetes centre some years ago, we found that most of the primary care referrals had significant clinical discrepancies, we'll call them, or errors. The patients weren't taking what was described in the formal referral in most cases. And so that reinforces to us that as clinicians we should always check with our patient that they are following through as prescribed and as they've agreed in terms of taking their medicines. So there, in conclusion, is a strong rationale for use of medicines in people with diabetes, and that links in with the rational use of those medicines. Consumer advice can help us shape our therapies. We try and take into account the risk-benefit situation in terms of medication use in each case. Many of our medicines are derived from flora and fauna, and I'll leave you to consider that many of them that I've mentioned, the active ingredients have come from the world around us, the natural world, and then been further refined in the laboratory. And in terms of further progress, we will find that there'll be safer methods of administration with fewer adverse effects. Already there's combinations of medicines to minimise burden of pills or injections and to optimise efficacy. And we will find as well that we'll be able to better personalise and target care in people with diabetes at risk or with complications. So hopefully that's been helpful for you. We've completed this agenda now, and nice to have a linking back to nature picture, and also some joy in that toe, reflecting hopefully joy we can bring to our patients and their carers in the management of diabetes and preventing and managing complications. Thank you for your time.
Thank you, Stephen. Diabetes disproportionately affects Aboriginal and Torres Strait Islander people, with those living in remote or very remote areas of Australia being more likely to have diabetes than those living in non-remote areas. Dr. Jason Agostino and Pippa Travers-Mason will highlight opportunities available to strengthen the health of Aboriginal and Torres Strait Islander people and the role of embedding pharmacists within primary care teams.
Thanks. I want to acknowledge that I'm on the lands of the Gadigal people of the Eora Nation and pay my respects to their elders past and present. I'm Jason. I'm a non-Indigenous GP and epidemiologist who's the Senior Medical Advisor for NACCHO, and for over a decade I've worked as a GP at Gurani-Lamukka, which is the community-controlled health service for Yarrabah on Gulgandji country. And over my time at Yarrabah, I've always had the opportunity to work with Pippa, a pharmacist integrated within our service. And today, Pippa and I are going to talk about diabetes in Aboriginal and Torres Strait Islander communities with a focus on the quality use of medicines. So hopefully everyone here is very well aware of the disproportionate impact that diabetes has on Aboriginal and Torres Strait Islander people. This graph shows the rates of death over the past 20 years, and we can see that there have been improvements when we look back in time. But things have slowed down in terms of improvement over the past decade, and the rates of death for Aboriginal and Torres Strait Islander people due to diabetes remains almost 5 times higher than non-Indigenous Australians. Behind that higher rates of death, very high prevalence of diabetes amongst the population. And diabetes starts early, with the age of onset for type 2 typically around 20 years earlier than that of non-Indigenous Australians. Within that really high prevalence, the prevalence is highest within those that live in remote communities. And this graph shows prevalence increasing with age. And by the time we get to our older Aboriginal and Torres Strait Islander people, we find that 1 in 3 living in non-remote areas have diabetes, and almost 1 in 2 in remote communities have diabetes from the age of 55. Of increasing concern is youth onset type 2 diabetes. And there was a study by Menzies around 2 years ago which documented that Aboriginal and Torres Strait Islander kids in Central Australia had the highest rate of youth onset type 2 diabetes in the world. This illness is particularly aggressive, and data from First Nations people in Canada has found that historically 50% of these children end up on dialysis within 20 years. The drivers for youth onset type 2 diabetes are largely around diabetes in the mother. Because we've had diabetes starting earlier and earlier for the Aboriginal and Torres Strait Islander community, we now have around 1 in 50 Aboriginal and Torres Strait Islander mums who have established diabetes at the time of pregnancy, and a further 1 in 8 develop gestational diabetes during the pregnancy. So the key to trying to turn around these figures around youth onset lies around supporting women to live healthy lives, and in particular, if they choose to become pregnant, intensive support throughout their pregnancy and afterwards. Another distinguishing feature around diabetes among Aboriginal and Torres Strait Islander people is the level of comorbidities. So this diagram on the right shows the overlap between diabetes, cardiovascular disease, and chronic kidney disease. And you can see in the green circles for diabetes that very infrequently does it occur on its own. It's much more likely to happen with 1 or 2 of these really significant comorbidities. When we're thinking about how we tackle diabetes, we don't need a disease-focused approach. We need something that thinks about the whole person and thinks about their whole community. And that's what Aboriginal community-controlled health organisations were developed to do. So NACCHO is the peak organisation representing 146 of these services that are spread around the country on that map on the left. And the distinguishing thing about these services is that each one is governed by a locally elected Aboriginal and Torres Strait Islander majority board. We're quite old now, and the first service opened over 50 years ago around the corner here at Redfern. And central to the model of care developed by community controlled health services has been a definition of health and an idea about health that extends beyond just the physical well-being of an individual. From the outset, ARCHOs have been focused on the social, cultural and emotional well-being of an individual and their whole community. And it's this type of holistic care that's required in order to address diabetes. Another thing that's distinguishing about our services is that the majority of the staff are Aboriginal and Torres Strait Islander people. So as well as our Aboriginal boards, which establish the cultural authority of the practice, we also have a number of Aboriginal staff supporting culturally safe care. Our services are growing, and our footprint is. But despite that, we know we need to keep getting bigger, because there are around 140,000 Aboriginal and Torres Strait Islander people who say that they would like to access an ACCHO today, but can't due to access in their local area. When we look at what's happening around diabetes within our services, the number of patients that we're looking after with type 2 diabetes is increasing, and there's now around 40,000 Aboriginal and Torres Strait Islander people across our footprint. Those people are supported by a large, complex, multidisciplinary team, which is really different from what we see in other general practices. So me as a GP, I'm generally surrounded by 3 primary care clinicians. So I have the real good fortune to work with a lot of nurses, Aboriginal and Torres Strait Islander workers, and Aboriginal and Torres Strait Islander health practitioners. In addition to that, we have a number of visiting allied health services, of which non-dispensing pharmacists like Pippa are part. We're starting to see the evidence of the impact of this model of care, and this graph on the right shows results from our key performance indicator relating to diabetes and the proportion of patients with a HbA1c on target, less than 7%. And you can see the improvement over time since 2020. And what that means is that there are now an additional 5,500 people receiving care in our clinics that have their HbA1c on target, compared to only 5 years ago. But there are things that are holding us back. And one of the things that is holding us back is equitable access to new medicines for diabetes. The evidence is really clear around GLP-1 receptor agonists and SGLT2 inhibitors that they not only improve outcomes for diabetes, but also those comorbidities that we're talking around, cardiovascular disease and chronic kidney disease. But despite all that evidence that I've talked about the disproportionate impact of these illnesses on the community, Aboriginal and Torres Strait Islander people have had the same access to these medicines as non-Indigenous Australians. This is in complete contrast to what we see around other new medicines such as COVID antivirals. When these came onto the PBS, we saw Aboriginal and Torres Strait Islander people access them at a younger age, and we also saw that people in remote communities got earlier access to these treatments. And that was in response to the recognition that Aboriginal and Torres Strait Islander people were dying younger from COVID, and that the risk of death was highest amongst people with greater remoteness. We are seeing some changes around SGLT2 inhibitors. And recently, the PBS changed so that all Aboriginal and Torres Strait Islander people with diabetes could access an SGLT2 inhibitor due to their risk of cardiovascular disease. But that's where it stays at the moment. And it's not clear about what that means for access to co-prescribing around GLP-1 receptor agonists or for the other indications around use of these medicines. The other thing we need to do to accelerate the progress that we're making around improving outcomes for Aboriginal and Torres Strait Islander people with diabetes is support quality use of medicines. And in that way, people like Pippa, I think, are really essential. As I said, I've worked with Pippa for over 10 years, and in my mind, she's been really key to the reason that the community was really quick to uptake GLP-1 receptor agonists. She's the person that spends the most time explaining medicines with our patients, alongside one of our local community members, and she's the person that tells me what's actually going on with medication use in the home. And so in 2018, 2019, NACCHO with the Pharmaceutical Society of Australia and James Cook University did a study to look at the impacts of people like Pippa. They're called the IPAC study. And what they found was that the impact of a non-dispensing integrated pharmacist within an ACCHO was that patients had greater adherence to their medicines, they had greater self-reported quality of life, they had improvements to their HbA1c, and their eGFR improved when in normal circumstances it would decrease. Unsurprisingly, the MBS Services Advisory Committee, when reviewing this evidence, showed that it represented good quality for money in terms of improving outcomes for Aboriginal and Torres Strait Islander people. However, 2 years on from that finding, we still don't have sustainable funding to support people like Pippa to do the work that they do for communities. So I'm going to finish up there, and I'm going to hand over to Pippa to talk about how it is that non-dispensing pharmacists like her within community-controlled health services achieve the outcomes they do.
Hi, my name's Pippa Travers-Mason. Thank you for the invitation to come here and speak about a topic that I hold very dear and an area that I've actually been working in for many, many years now. Thank you, Dr. Jason, for the kind introduction. It's lovely to be back down here in the Eora Nation, which is actually the area that I grew up in. But currently, and for the last 15 years or so, I've resided in Far North Queensland. And through that time, I've had the opportunity to work with the beautiful community members of Yarrabah on Gungandji country. And I'd like to pay my respects to all of my Indigenous colleagues that I've had the pleasure of working with and the elders past, present and emerging. So when I think about medicine, and my background is in medicines, as I guess a medicines specialist, as it were, I think about it in a very broad sense of the term. When I'm talking about medicine, I'm talking about all the different therapies of a non-surgical means that we can use to promote healing and wellness in the people that we're caring for. In the Indigenous populations, this is actually a really important delineation or nuance that I certainly was made aware of many, many years ago when I first dipped my toe into working in this space. And something that I've found through my years working with the people of Girrawhee at Girrawhee Health Service is something that resonates a lot with community members. It's not just about the medicines, although medicines are a really important part of what I'm doing on a day-to-day basis. When we actually go out into community, this is a few examples of some of the acquisition of medicines that I find in people's homes that they are handing back over to me on a regular basis. So the first time I saw this kind of thing was probably over 25 years ago when I travelled around Australia and worked in different Indigenous populations. And to be honest, I was quite shocked and dismayed, but it made me really think about, well, how can we do this better for people? Fast forward many years later, and I was lucky enough when I moved to North Queensland to have the opportunity to work embedded inside an Indigenous health service. Now, I started working with Girrawhee back before they were a NACCHO run or community controlled health service, and right through the transitional period. So I've seen a lot of changes in the way that we do health there. And I've been very honoured to be a part of some of the improvements that we've been able to do over time, including something I'm most proud of, which is training the next generation of Aboriginal health practitioners and health workers to take on a lot of ownership of these roles and really help their community members to not just live, but thrive, and not just live longer, but live better with a better health span. So I often get asked, well, what does that actually mean? What are we doing as an integrated pharmacist? So if I think back to what I used to do, it's probably the easiest way to explain it. So historically, allied health professionals, and indeed a lot of medical professionals, would come in and out of community. And certainly that was the model that I was first introduced to many, many years ago. What I've been able to do at Yarrabah, and what I really do feel is the driver of change and improvement in health, is being on the ground regularly, being a face and a voice that the people recognise, being lucky enough to be asked for, firstly by name, but also I'm often referred to as the Bony Migaloo medicine lady, which was a nickname that was given to me over a decade ago. So it's not just about the medicines, as I said, it's about understanding what the people know about their health, about their outcomes, and trying to assist with information to allow empowered decision making. Now, it's bush medicines, it's lifestyle, it's connection with culture, social emotional well-being. It's all so intimately connected with the health space that it's really hard to tease these things apart. What I've found works really well for us is having the opportunity to make the relationships, work closely with my Indigenous health practitioner and health worker colleagues, my local nursing colleagues, some of which are Indigenous as well, and my local doctors too. We've got a very mixed group of health professionals working out where I am at Yarrabah, and we do, in general, work very closely together and allow the patient to be very much the centre of the journey and respecting their wishes. So I found that a lot of what got me started was really putting on my detective hat and having a good listen and a good look around and trying to work out the landscape. What happens out in Aboriginal health communities, and indeed in a lot of aspects of medicine, is there's this disconnect between people wanting to do the right thing, but not necessarily having the right knowledge to be able to do these things for themselves. Diabetes is a really core area within this. As Jason mentioned in his slides before, it is a really large concern in the population of people that I assist with the care for. And it can come very young in this population. And there are so many people affected that it almost appears like it is a genetic thing being passed down. And yes, there are aspects to that. There are also a lot of aspects that we do have control over. So in my practice, that's where I really like to focus. I spend a lot of time educating people on the things that they can do, empowering them to eat good foods, empowering them to connect to country, to really reflect on what the old people were doing. The old people didn't really get diabetes, but they also had incredibly different lifestyles to what the people of modern day, certainly historically, were subjected to. And unfortunately, the situation that we have is people not eating well, not moving their bodies as much as would be ideal, and a lot of these health repercussions and metabolic disease coming as part of this. So what we try to do at Gurani in our programming is empower people to ask questions about their medicine, empower people that they do have the possibility to create this change, particularly in our younger populations. I love going out and speaking to families where they have youth affected by diabetes, because that's the area where they can really start to turn things around and prevent the horrible statistics that Jason has just outlined to us all in this presentation that I'm sure everyone is aware of. So for me, what makes the difference is being part of the team, being a face that people recognise, and being a trusted source of medicines related knowledge in the context of all of the health knowledge that will encourage our patients to thrive. So in the context of all of the medicines that we have to offer people and all of the different medical interventions to help improve people's health, improve their longevity and their health span, we can't underestimate the power of what we do and say to our patients and how that can be so integral in people being empowered to make the positive changes to improve the health of themselves and their whole families. Thank you.
Thank you, Jason and Pippa. Further emphasising the importance of addressing the community need through innovative models of care, Professor Shyamasundar Acharya will share how integrating diabetes care across regional, rural and remote communities transforms diabetes care.
Hi everyone, my name is Shyam Acharya. I'm an endocrinologist and Director of Endocrinology and Diabetes at John Hunter Hospital. Today at National Medicine Symposium, I'm going to introduce you on behalf of our partner organization, our Diabetes Alliance Program Plus, which is a transformative integrated care program across regional, rural, and remote communities. I would like to pay my respect to all elders past, present, and future. I come from Awabakal land and I pay my respect to elders everywhere in Australia. This is the artwork that captures the work that we do with our Indigenous community. Credit to Jody Reynolds, our artist. All these circles actually represent individual communities that are coming together, facilitate a discussion about diabetes. Bright colors indicate positivity and no discrimination or stigma. Little bit about the landscape of diabetes care in Australia. An estimated 1.5 to 1.7 million people in Australia have type 2 diabetes. However, 30% are yet to be diagnosed while their disease is advancing. Although we know that diabetes prevalence is reaching around 12% across most states in Australia, GP practice databases are coding only 6 to 8% of diabetes, which is largely due to insufficient screening and improper coding. An estimated 3.4 billion Australian dollars were spent on diabetes care in 2021, which adds significant cost to the taxpayers. Diabetes, in addition, contributes to at least 10% of all hospitalization across 1.2 million admissions in Australia per year. Despite this large number, we don't seem to be doing well. Only 70% are currently diagnosed with diabetes, out of which only 50% are receiving appropriate evidence-based care, out of which only 50% are achieving target glycemia, and only less than 50% are leading a life without complications with diabetes. These pictures depict the complications of diabetes. Diabetes is overrepresented in our hospitalized patients. At least 20 to 25% of our hospitalized patients have diabetes, and their length of stay is 1 day higher compared to someone without diabetes. Not only that, they seem to acquire multiple complications while they're admitted to hospitals. This atlas of Australian healthcare variation shows that further you live away from metropolitan cities, the risk of preventable admissions related to diabetes increases enormously, showing at least 12-fold variation. If you lived in Sydney, your risk of admissions due to diabetes is anywhere between 64 to 104. However, if you lived in Northern Territory, the risk of admission goes to 1,600 admissions per 100,000 population. There are some serious misconceptions about diabetes, that diabetes is always preventable. While 65% of type 2 diabetes may be preventable, the rest of them may occur due to multiple other reasons. Diabetes is actually a heterogeneous group of metabolic conditions. It is not as simple as type 1 or type 2 as we think sometimes. Type 1 diabetes also can occur at any age. 10% of all diabetes is due to type 1 diabetes in adults. And unfortunately, adults with new onset of type 1 diabetes are often misdiagnosed and mistreated. There are many other types of diabetes, such as pancreatogenic diabetes, monogenic diabetes, and genetic forms of diabetes are not receiving appropriate clinician attention. While lifestyle changes are highly essential for everyone with diabetes, however, the evidence shows that lifestyle changes alone is insufficient to prevent complications of diabetes on many instances. Timely and appropriate use of medications improve prognosis and survival in diabetes. However, clinical inertia is very common due to resource constraints and stigmatization in diabetes. Delayed treatment escalation results in premature morbidity and mortality. At any given time, 25 to 85% of our patients suffer the consequences of clinical inertia. When we consider breast cancer or melanoma being treated in the same way, would we consider the suboptimal outcome? Something we need to think about. We established this partnership program back in 2014 called Diabetes Alliance Program, which is a partnership program between state-funded Hunter New England Health District and Commonwealth-funded Primary Health Network, with our primary vision to enable GP practices to deliver high-quality clinical for most patients with type 2 diabetes within the space that they are familiar with. At the same time, improve timely access to specialist care. Just a bit of background about our Hunter New England Health District. We are 2 hours north of Sydney. We cover a large geographic area comparable to that of country England, 130,000 square kilometers. Around 1 million residents live in Hunter New England Health District. 100,000 people have type 2 diabetes. 30% are yet to be diagnosed. We have 300 general practices, 1,000 individual general practitioners, and we had 3 full-time equivalent public endocrinologists in our system. Unfortunately, what was high instances of preventable admissions related to diabetes complications. And Initially, we started addressing this through guidelines, health pathways, referral criteria. However, the impact was not fully obvious until we started getting into general practices. In this Diabetes Alliance Program Plus, we have 5 arms. Initially, we started a DAP program as a pilot project back in 2014. Due to overwhelming success and demand, we made it as business as usual in 2017. By 2022, we received a large-scale philanthropic donation, which enabled us to scale this up to rural and remote parts of our district. We have 5 arms at present. First one is the benchmarking data appraisal, where the data is captured from PenCat software, and detailed performance appraisal is given over lunchtime to participating GP practices from visiting endocrinologist. And then we spend about 2 to 3 days in the GP practices conducting case conferences with general practitioners and case practice nurses in an attempt to build capacity. We also have master classes across our districts conducted over evenings and weekends. And most recently, we have introduced virtual case conferencing for general practitioners. We have introduced advice line for any clinician across our district. And also, most recently, we introduced Australia's first ever diabetes-specific Medibus, in addition to specific digital lifestyle modules, which I will be showing you over the next few slides. We have thoroughly evaluated all the relevant clinical and economic outcomes of our program. We have also evaluated clinician acceptance and satisfaction, consumer acceptance and satisfactions, patient activation measures, and sustainability of this program. And we have thoroughly assessed the assessment of our entire program. When it comes to GP practice data extraction, initially we partnered with NPS MedicineWise. However, subsequently we developed our own in-house based on PenCat audit. Here, the data reporting has the benefit of ability to re-identify patients when we are in the practice, so that the GP practices can use it as a quality improvement program, which is fully approved by RACGP. Our program managers visit the practice, identify the patients who need our assistance, and then we schedule a full day case conferencing within the practice. This is how detailed our performance appraisal, which pays attention to all the necessary process measures as well as the outcomes within the practice. In terms of case conferencing, endocrinologist, diabetes educator, general practitioner, and funded activities. Each case conference is about 45 minutes long, where all aspects of diabetes, including lifestyle, medications, complications of diabetes, are discussed and recommendations are made, and GP and practitioners take the ownership of implementing recommendations by the specialist team. Here, the model of care is, while we are treating the patients individually, GP and practice nurses are active participants of listening and learning. The expectation is that the lessons learned during these case conferences are then transmitted to the rest of the practice patients with diabetes. Clinicians' masterclasses have been immensely popular. These sessions are conducted throughout the health district across evenings and weekends. All aspects of diabetes have been covered in these master classes. In terms of clinical effectiveness of our integrated care model, the initial data from 20 practices show that even one-off case conferencing led to significant improvement in HbA1c levels, lipid levels, blood pressure levels, weight, and cardiovascular risk profile. However, we also saw significant variation in primary care in terms of diabetes process monitoring. For example, here, some practices, as shown in the green bar, have very high incidence of annual HbA1c testing, whereas some practices are only testing HbA1c in small minority of their patients with type 2 diabetes. This is of significant concern, and education and resource might help us to improve this variation further in the long term. While we are interested to improve individual patients' outcome, our larger interest is to see the spillover effects from the lessons that were transmitted during the case conference. So here we looked at 72 GP practices that have received Diabetes Alliance program intervention, and we looked at the data 1 year before and 1 year after. And what it shows is for every 1,000 case conferences we do, indirectly from the lessons learned, 22,000 patients appear to improve their parameters in terms of improved process measures and improved outcomes by appropriate intervention from their general practitioners. Not only that, the model has also shown that when we compare our integrated care model with that of traditional hospital model, Diabetes Alliance program is about $108 cheaper compared to hospital model, although we are taking the team out into the GP practices. From 2023 onwards, we have been seeing nearly 60 new practices every year. And we have also developed a dedicated 1-300 advice line to clinicians across our district. 50% of our calls come from peripheral hospitals, 50% come from primary care. We have enabled video-enabled virtual case conferencing for general practitioners. We have also introduced digital apps such as physical activity, nutrition, and mental well-being. These apps are very easy to use, and they are self-guided activities developed by the University of Newcastle. We have also developed our First Nations Aboriginal specific YANAP models for our Indigenous community, which has been co-designed with our First Nations elders. We have also built and commissioned a Medibus for rural and remote communities. So far, more than 200 out of 300 general practices in our district have participated in this program. Around 7,000 individual case conferences have been conducted, and more than 90 GP practices have participated in virtual case conferencing. Across 100 master classes, more than 3,000 clinicians have completed learning activities. So far, we have shown that it is possible through an integrated care program such as Diabetes Alliance program. It is possible to improve patient outcome at a large scale across rural, regional, and remote parts of Australia. These models have been extremely well received by our clinicians and patients, and the data has been published. This is a cost-effective model, and the spillover benefits appear to be quite important from the learnings that have transmitted during the case conferences and master classes. This is our program logic model developed by Professor Alexis Hure and our team, and we define our need as the diabetes population. Our aim is to reduce the burden of diabetes in the community and improve their survival and outcomes. And these are the outputs, and these are the impacts, such as hospitalization. We are currently measuring a better experience for our consumers and clinicians. The economic sustainability also we are measuring. This is our Medibus. Beautiful artwork again by Jody Reynolds, depicts what we do with our Indigenous community. Bus has a consultation room, a satellite internet that can link up specialists across the state, for example, and clinicians such as GPs can be brought into the consultation room, or they can join virtually. Our managers would be very happy to have you on board for this mobile clinic consultation. Medibus basically is a magnet. It has multiple purposes. First of all, it's the advocacy and destigmatization about diabetes. We want people with diabetes to come forward, get tested, and get sorted. That's one of the important messages. We are hosting community events, and we promote lifestyle intervention very heavily during these community events. We enable multidisciplinary consultations including podiatrists and dietitians and pharmacists during these rural remote trips. As I mentioned earlier, there is a video link available for specialists. If they are not a part of the in-house bus team, they can be brought in from other places. We were fortunate to have had an invitation to take the bus to Australia Diabetes Congress recently at Gold Coast, which was attended by more than 2,300 people, and we received a very positive feedback. Not only that, bus will be in Melbourne next year for International Diabetes Federation meeting as well. We have introduced multiple digital modules. These are very easy to use, no time, no money. This is developed by Professor Claire Collins from University of Newcastle, which addresses the nutritional needs of our community. Anyone can use this. These are free to use, not restricted to people with diabetes. Similarly, EcoFit is an exercise-based app which can be used by anyone at all level of fitness. You can do these activities at home or at the outdoor parks. We also have a mental well-being app. This is for reducing the distress from any chronic illness, and this is developed by Dr. Dara Simpson and her team. I should thank all our team for putting massive efforts to try and solve this problem that is causing grief in our communities. Finally, I just want to take a minute to explain integrated care models such as DAP and the importance of reduction in hospitalization. Our primary interest is to reduce hospitalization from diabetes. That's where most of the sufferings eventually happen. So what we did was we partnered with Lumos state-based database, and through HMRI, our medical research institution, we took data belonging to 100 GP practices from Alliance. We had propensity matched 15,000 of our patients to 15,000 patients elsewhere in the New South Wales health districts who have not been exposed to any form of such integrated care. And then we looked at their admissions compared to our own cohort's admission over the last 10 years. And I'm very pleased to say that we are reducing admissions related to diabetes through DAP intervention. We have seen around 10 to 12% reduction in hospitalization, which again comes down to quality use of medication, education, and capacity building in the community. We are also seeing some early reduction in the mortality, and these are not necessarily all the patients we have seen. We have seen perhaps 30 to 50 patients in these practices, and the lessons learned during case conferences are getting transmitted to rest of the practice patients with diabetes. So in summary, Diabetes Alliance program was associated with reduction in all-cause hospitalization of about 10 to 18% over the last 5 years. There have been 12% reduction in the length of stay, suggesting reductions emerge over time. And further research is needed to understand what complications we are actually reducing. And the earliest inclination is that perhaps this is from cardiac failure and renal failure related to quality use of SGLT2 and GLP-1 analogs. As I mentioned before, any healthcare gain is due to combined effects of access to care, which still remains highly challenging to our rural and remote communities, quality use of medications, and patient and clinician education. I would like to thank our dedicated and passionate staff who made this work really possible and effective. I would also like to thank our researchers from Hunter Medical Research Institution and University of Newcastle, our execs across all 4 organizations. I would like to thank our Colonial Foundation for the philanthropic gift. And I would also like to thank our primary health network, our primary care clinicians and staff who tirelessly work to make this highly successful. And finally, I would like to thank the organizers of the National Medicine Symposium for their kind invitation. Thank you.
Thanks, Shamasunda. So far, we've seen how quality use of diabetes medicines can be shaped by the type of diabetes and the models of care that support them. Now, we're going to take this further and focus on the primary care setting. This is where most people living with diabetes are managed day to day. Safe, effective, and person-centered care comes to play in this setting, but also where many barriers and opportunities arise. I'm delighted to welcome our expert panel who will share their perspective on strengthening diabetes medicines management in primary care. This discussion is guided by the questions you have submitted when registering for the symposium. I'd like to welcome Renza Shibilla, diabetes advocate, and also, of course, manages her blog, which is called Diabetogenic. Also, Distinguished Professor Dave Simmons, Professor of Medicine, Western Sydney University, Chief Medical Officer for Diabetes Australia. Dr. Gary Deed, Chair of the Diabetes Special Interest Group, Royal Australian College of General Practitioners, and of course, Adjunct Senior Research Fellow at Monash University and a General Practitioner. Ms. Kiralee Chambers, Advanced Practice Pharmacist and Credentialed Diabetes Educator, Diabetes Education and Management. And also Associate Professor Marg McGill, Nurse Manager and Associate Director, the Royal Prince Alfred Hospital Diabetes Centre. Welcome all. But I thought what I might do is start by asking each of you a bit about your perspective, and you bring different perspectives about diabetes medicines management in your setting. And Renza, I might start with you to open the batting, just about your perspective on some of the challenges that people living with diabetes face around medication management.
Yeah, sure. So my personal perspective is that I've lived with type 1 diabetes for 27 years. So I'm very much speaking from my own personal experience. There's a constantly changing landscape in diabetes, whether it be technologies or medicines or care plans, whatever it might be. So one of the real challenges for people living with diabetes is, I guess, staying up to date with all of that and making sure as well that their clinicians are across all of that too. So I think that there are a number of different challenges. And of course, those challenges are going to be very, very different depending on a person's own experiences. So this is such an important topic, I think, to be discussing. But I would be really mindful that there is no one size fits all and that we need to be, really, I guess, responding to what individual needs are and making sure that we're finding out what they are in the first place and then addressing them as they come up.
Thanks, Renza. We heard there about some of that complexity, Gary, and I wonder, just from a higher level point of view, if you were thinking about some of the challenges in medication management, people living with diabetes, what would be your perspective you'd put to the panel?
From general practice, I mean, the perspective that probably is constant is it's also always person-centric. You have to treat the individual, and that requires a skill and a training. And general practitioners are quite good at looking at complex chronic illness now. We've got good training models and putting the person at the centre of that. But diabetes is one of the classic complex chronic conditions that has multiple other factors. You've got high blood pressure, cardiovascular. So the complexity is, how do you create a system that's patient-focused, practice safe, and allows quality use of medicines. And that skill is in good training, good systems, good staff, and underlying good education. But at the end of the day, it's good heart, listening to the patient and treating the person.
Sure. Okay. Marg, your perspective around this? Primary care is obviously a place where most people living with diabetes are cared for. And I appreciate from your perspective, you've got a unique take on this. Any thoughts you'd like to share in the initial part of our discussion?
Yes, I mean, I've worked in diabetes for many decades, and in the old days, it really was quite straightforward. We were limited in the medications we had and limited in the insulins. In the last 10 years, there's been an avalanche of new medications. And these medications are very good and very helpful for people and improve outcomes. Yes. But it makes it very complex for the primary care people as well. And so I think linkages between tertiary care models and primary care models are even more paramount than they were before. So keeping in touch with our primary care colleagues so that people can get the best care possible is absolutely essential. There needs to be two-way communication.
Good. We're going to come to that multidisciplinary care in a moment. But Kirli, just from a opening sort of comment point of view, we've heard a bit about the complexity of medicines, and obviously you're right at that coalface. Any thoughts that you'd share initially?
Yeah, certainly. From a pharmacist's perspective, it makes it even more complex in that there's lots of swapping between medicines when you've got generic substitutions, which makes it even harder for the person to understand when they're getting different brands. There's lots of confusion, and I would say one of the pivotal things is education, which not every person can have the opportunity, but every person should have the opportunity to get.
And I know you're a diabetes educator, of course,
Yes.
so that's education about the health condition, about how they can best management, but of course you're also talking about the critical role about understanding their medicines and how that works.
Yes, so there's lots of opportunities to tap into things like diabetes meds checks, which is a government initiative that has been paid for pharmacists to do a simple education about their medicines, which allows for less confusion, which can then lead on to something called a home medications review, which is done by a specific pharmacist. And these are all education appointments that can be allowed for a person with a multidisciplinary healthcare team. So tapping into those education sessions can be very helpful for a person.
Yeah, no, obviously there's the education during that session, but also hopefully the outcome is about a better understanding of their medicines and maybe, you know, an optimal regimen as well, because I know they're all conducted in collaboration with the general practitioner.
Yeah, and as Mark said, then we allow for better education, better education for all of the people and their families.
And David, I might throw to you just in our opening comments there about any perspective you might bring just around some of the challenges of primary care before we dive into some of the detail.
Yeah, thanks, Andrew. I think my perspective obviously is another one. So from a specialist point of view, any of our referrals will have already come through the GP for a number of reasons, or they'll have come in through the front door of the hospital as an inpatient or in the emergency department. So we really do see filtered people who are at the kind of the pointy end, some of whom unfortunately come in with avoidable complications, and others will come in from either side effects, not taking their medicines, and so forth. So it really is a slightly different perspective, perhaps. And I think, as the panel has said, you know, education is a big part of it. But I think we have to remember, I work in a multicultural area. We have lots of issues around people understanding. It's whether it by language, whether it by culture, whether it by health literacy, which is really important, or even numeracy. We always have to think about these things, and sometimes these are reasons why there have been issues and why someone's come through the front door of the hospital. And then, as Mark said, we have to work very closely with the GPs and try to support them, because knowing the whole breadth of what's going on and deciding what's the next medication, what's going on, is very hard. And we have to set up systems to support the GP. You know, I'm very lucky. I sit within a multidisciplinary team. Again, who I see is usually filtered by the diabetes educator, by the dietitian, and we're able to put forward a package. In the Australian system, sometimes that's quite challenging for a GP, particularly in an area where there may not be access, for example, to a dietitian or an educator readily. And also there are out-of-pocket expenses, which again add those extra barriers. So I kind of look at it at that perspective, you know, how do we stop people coming in through the door and allow me to focus on the ones that perhaps I would, to stop them developing the complications rather than downstream.
Thank you. Renza, David mentioned multidisciplinary care there, and I think it's a theme we might just spend a bit of time on. And I wonder about your observations and perhaps experience with not only the multidisciplinary team, but also perhaps the value of that.
I think that having coordinated care is critically important, and having a multidisciplinary team that speaks to each other is you know, critical. You know, there's a real frustration, I think, for people with diabetes when there isn't that communication across the team, and it feels like every single time I sit in front of a new health professional, I'm starting again. But I just want to point out, we've been talking about multidisciplinary teams and we've mentioned some of the people in there, and nobody's mentioned a psychologist. And I think that that is one of the real gaps in terms of diabetes care. mental health care is diabetes care, and diabetes care is mental health care. There is far more to diabetes than just the clinical aspect. So one of the things that I would really urge people is that when you're thinking about that multidisciplinary team, is to think about how is it that we can also access psychologists, social workers, counsellors, anybody who's looking beyond just the clinical, because often it's not possible to even start to talk about diabetes care when there is somebody who is dealing with a lot of emotional issues and psychosocial issues as well. So that, I guess, is always my point is, I remember being diagnosed, I was given this whole new team of people that included a dietitian, a podiatrist, an ophthalmologist, diabetes educator, an endocrinologist, all important, but nobody said, hey, and maybe you want to talk to somebody about this. And that would have been the most important thing, I think.
Thanks, Renza. Gary, I think some good reflections and insights there about that team, and I often feel it's the GP who is doing a bit of that coordination and is the centre of the hub. How do you go about optimal care in that setting, particularly around some of the medicine's complexities?
I think you use a chronic disease model. So, GPs are trained. We've got the systems that support that. So it should apply to diabetes, should apply to any other chronic illness which overlaps with that. So it's actually knowing that a team-based coordinated approach is the basis of the model of care, and trying to develop those networks, both tertiary care, pharmacy care, psychologists, dietitians, etc. And the GP really is the person helping the person play their own tune. You might need a dietitian this week, Andrew. Next month it might be the psychologist. And the GP has access to systems and referral process and government-supported schemes that allow the patient to get access to that. So it's really developing a really good communication with the patient and developing your own network. And those networks are easy to develop if you've got a good systematic approach to chronic illness. Mm-hmm.
Marg, obviously you work in a multidisciplinary environment, and maybe all those teams are in the same room or just in the rooms next door. Maybe just your thoughts and reflections on what you've heard from Renza and Gary.
Look, Renza's absolutely correct. I think if we just go down the science model, where we're only talking to people about their medications and their complications and their hypos, that's not what it's all about. It's about living with diabetes. And to be perfectly honest, there will be a small group of people with diabetes who may need a psychologist. But if the majority of people living with diabetes really just want to be heard by a health professional who understands, who gets it, who knows it's difficult. And so I would hope that in our training as GPs, as diabetes educators, as endocrinologists, we think about not just the science and the clinical aspects, but we think about the art of medicine. Because when we're more well-rounded, we'll do a better job with people with diabetes.
And I suppose to Renza's point too is once you identify the need, then identify the right team member who can support a person living with diabetes.
Well, I say to my staff, the person with diabetes has to walk out your door feeling uplifted and ready to keep going. Why should they come back and see you if you haven't added value?
Sure, that's lovely. Gary, sorry.
I think we need to emphasise that there are community resources that can translate your scientific understanding of that person's diabetes into patient-friendly, culturally, linguistically diverse resources, such as through Diabetes Australia, the National Diabetes Services Scheme. There are wonderful ways that you can translate your clinical care and get supported by these community resources. And there are medicines resources in there, insulin resources. Use them wisely and use them widely. And it's important in clinical practice.
Yeah, so being aware of what's available and connecting people with, their understanding. I think David's point too about health literacy and numeracy becomes really critical when we're managing, diabetes and particularly some of the complexity of medicines. So we might dive a little bit more into the medicines. And one of the questions and comments that came up was some of the challenges of medicine shortages, which have been occurring. Maybe they're not so bad right now, but also some of the insulin discontinuations. And Marg, I know you spend a lot of time talking to patients about optimal regimens, and while there may be a decision to change a medication regimen, you might be the person, and Kirili, I'll come to you in a moment as well, who might be dealing with how to explain that to someone. But maybe you could just pick up on some of the challenges around the insulin discontinuations.
Yes, so not only are there insulin discontinuations, there are sometimes the pen device discontinuation as well.
So device, yeah.
And we know that people are living longer. We know that age is the biggest predictor of type 2 diabetes. So we now see many referrals of people in their 80s and 90s. Some of these people need to go onto insulin. And when we lose the simple devices, the other devices are sometimes people don't have the dexterity to put a pen fill into a pen. And so that really impacts. So there's that side of it. Then there's the side of the insulins that are being discontinued, say, for example, that we use predominantly in people with type 1 diabetes, and there's not a decent substitute for those insulins. Most people don't have health insurance and can't afford pumps. So I have to say, as a health professional, it is frustrating, but we will work with our people with diabetes to ensure that they get the best care, but there is a frustration about that.
And here we've got that, what guidelines of best practice might be, what's affordable, what's accessible, and also, of course, the difference between different practitioners. And Kiralee, I'm familiar with the idea that you're navigating this space for patients to help them be able to access the medicines they need in a timely manner. Do you have any observations about some of the current challenges in that space?
Yeah, we see a lot of multiple scripts happening with discontinuation and difficult to get.
So when you say multiple scripts, that if you can get this, here's that script. If you can get that, get this script.
Yeah, and so then when medications come back onto the market from, there being issues with scripts not being able to get, then people will often get both medications because they've forgotten that the GP's given them one script and says, well, get this script while this medication's unavailable, and they forget that.
Can I press you to give us maybe an example, given some people online will certainly understand those medicines?
Yeah, so semaglutide. So when Ozempic was unavailable, they would be getting scripts for things like Januvia. And so they will have gone and got their script for Januvia for 6 months, and then all of a sudden they've gone to the pharmacy and the pharmacy will say, oh, Mrs. Jones, your Ozempic's back, would you like one? And they go, oh, yes, please, forgetting that the GP or the specialist has said only get your Januvia while your Ozempic's unavailable, and so that now they're on multiple medications.
Right.
And a GP who I have a lot of respect for had said to me once, pharmacists will only ever ring me when there's a problem. And it kind of changed my perspective of some of the phone calls I was making.
Sure.
Because it's not always, we don't always will ring another healthcare professional when there's a problem. We'll often ring to get some advice. So now we're seeing multiple people on multiple medications that they weren't on before.
Yeah.
So we're ringing to say, hey, did you really mean to put this person on multiple things? Because now we've got multiple medications of people that they weren't on 6 or 8 or 10 months ago. And this has happened from there being multiple medications that were unavailable. So we're ringing to say, hey, just a heads up, 6 months ago this person wasn't on all of these things. And this is part of the de-prescribing to keep people safe so that they're not bouncing into hospital.
So just to summarise a few points there, of course, regular meds check and maybe reconciliation of what someone is actually taking is kind of critical. Helping the person living with diabetes understand, what's the therapeutic approach, and obviously they're really important to do it. And lastly, about effective communication, I like that idea of being curious when you ring rather than judgmental, which is quite important. Renzo, we're talking about, I suppose, some of those changing environment around medicines, and I wonder if you had any observations or information that's come to you from your networks around some of the challenges of the insulin availability and maybe even the broader challenges of how medicines are used off-label.
Yeah, absolutely. So, I think we need to be very conscious that there is a very broad spectrum of people living with diabetes and their understanding of what is available, what they might want to be trying, understanding what is going on in the broader landscape of access and availability. I think we need to be very mindful about the way that we communicate about what this is. And we had an example a couple of years ago where there was this big announcement that Fiasp was being removed, and there was a lot of concern about that. But what the response was a largely community-driven campaign that raised awareness about how important this was and how it couldn't just disappear. Now, the end result obviously was one, as Marg described there, where the drug has remained available on the PBS. However, the device of the delivery device has changed, but it is still available, which in some ways I guess is a win because it was going to be removed. And again, is there something that does exactly the same thing? Absolutely not. But I think that, off-label use as well is something that for people who are really informed and understand about what is available, want to have conversations with their healthcare professionals about how perhaps they can use a medication that is not necessarily prescribed, ordinarily prescribed for them. And we have seen that with GLP-1s. There are a lot of people with type 1 diabetes who are very interested to understand how that can be added as an adjunct therapy to their type 1 diabetes management for a variety of reasons, whether it might be around insulin resistance, helping with weight management, for renal and cardiovascular protection, all of these sorts of things. So one of the real challenges, I think, for primary care physicians and all clinicians really, is to be ready for people who want to have those conversations and be open to those conversations.
Thanks very much. And David, I'm aware we're on the point of some of the availability of medicines, including some of the insulin discontinuations. As Renza alluded to there's a lot of voices in the room, and I understand too that there's a bit of a national strategy here. Did you want to just talk about that?
Yes, obviously we've been trying to ensure that there are replacements for some of the devices that have gone. For example, for Protophane would be one, and we're trying to do that, and it's quite challenging. If you're working with people with, for example, gestational diabetes, then they only have a limited number of weeks to actually understand what they're doing, and some of the quicker learning devices are really quite superior to learning how to put a cartridge into a pen. But the one that we're most concerned about really is Levemir. Though for the vast majority, there may be a proportion in Australia, 20-30 can go onto a pump because they can afford it. For the others, there is no alternative to Levemir. There are some who can take the insulin once a day and go on to Glargine or one of the others, but there's probably 5 to 10%, and as we've heard from Renza, every person with diabetes is, of course, an individual, and we have to look at the risk for that individual. And for those who need Levemir twice a day, so it can cover during the night, then there's a big risk when we go from that to a once a day, and they need different doses. So during the day, they will be at risk of hypos. If they then, if they basically reduce their dose and put their glucose up, they're going to be more hypoglycemic at night, and therefore this will directly lead to those long-term complications. So this will come to the GP, for example, and they're going to come off to the cliff edge. They're going to give perhaps a once-a-day insulin, and those individuals, which may only be, as I said, 1 in 20, they're going to start having hypos, maybe perhaps when they're driving, if they haven't got a sensor on or if the sensor's not working. This is actually quite a critical phase for those, and we're only about just over a year away. So we are looking at strategies. I mean, these individuals, the only solution is really a pump. There is nothing else that's going to replace it for those individuals, and they may not be able to afford one. So we're certainly concerned about that, and GPs and pharmacists need to be very much aware that this is what's coming.
Yeah, so I think that awareness is something we can certainly do now, and of course I'm sure action coming out of the National Symposium this year, that's obviously a key theme, and not only what is optimal care in a changing environment, but also that idea of affordable access, which is a critical part of our national medicines policy for all health consumers. I might start to go to some of the questions that those people have logged online. I'm going to start, Gary, with yourself. There's from a GP point of view, and it goes to the idea that there are obviously guideline care, there's changing environment around medicines, and this is a bit of a theme you alluded to earlier, but about how do you individualise that evidence for an individual, for their needs, and also, as Renza pointed out, based on, I suppose, the choices. I like the comment that I've seen on Renza's blog about, no decision about me without me. So I wonder if you could just talk about your approach to, changing evidence, different devices, availability, and then the individual care.
I think different medications, etc. On the basis that diabetes might appear to be complex, you as a clinician and my other fellows need to have simple ways of addressing that complexity. One is that the evidence-based guidelines give you a framework, but you need to be educated about them, and that's why we work with tertiary care and MARGs for instance, is nationally leading in educating GPs around guidelines. I think that's a baseline of the pyramid of care. But then translating that into your own practice, you have to understand that diabetes, it isn't, people don't come in, they're not diabetic. They have diabetes as well as all these other conditions, including psychological issues, all those issues. So as a GP, the diabetes guidelines give you maybe medicines that are appropriate for diabetes, and you have to select that person.
Yeah.
In a complex algorithm, Andrew, when I'm sitting, you're coming to see me, I have to think, do you have high blood pressure? Do you have lipid problems? Do you have kidney disease? Do you have metabolic associated fatty liver disease? And how do I adapt that framework to the choices of medications and then negotiate with you? So be proud of our GPs because they often do it well.
Yeah, of course.
Right? Because they're well trained, there are educational processes and there are guidelines. That's how you do it. A well-trained, systematic approach and a very clear perspective of what that person is, not just physically, but also emotionally and how they live.
What about maintaining up-to-date information about what's on the PBS, what's funded through the MBS?
Yep.
You know, what's coming out? Where would you be pointing or suggesting GP and other health professionals get their information about medicines? I'm
proud that I help edit the Royal College of General Practitioners handbook on the management of type 2 diabetes. It's a massive undertaking, has a lot of information used by all health professionals and it should be utilised as well. And working with David and the Australian Diabetes Society, there's a lot of work we do and we do communicate out to GPs as well. So those systems are in place, but we always could be better.
Sure.
But reach out, the college has got really good resources for you.
Excellent. We are coming towards the end of our panel, so I'm going to do a quick fly around about maybe if there was one thing that you wanted to mention today about diabetes medicines management in primary care that we haven't had a chance to talk about, but maybe you could flag for the future. Kirralie, do you want to give us something?
That people try and remain as up to date as they possibly can, and if they could ask as many questions as they want, they would keep asking those questions.
Marg?
I think from a health professional point of view, I would hope that we can stop some clinical inertia.
Yep.
Because I think that is very important. It's very easy to have somebody say, oh, give me a few more months. And then that's easy for everyone, but it's not good for the person living with diabetes.
Yep.
For the person with diabetes, I want people health professionals to practice the art of medicine and not just see person as somebody who takes medications.
Wonderful.
They're a human being first.
Thank you. David?
Obviously building on Margie's comments, which is these are very much individuals, they have their own lives, and we really need to mould whatever we're doing around that particular person. Often we're asked particularly about the second agent, so I think people need to work and focus on what is the second agent. But again, sometimes that won't be needed if we've addressed some of those other reasons why that medication is in place and some of those barriers. So I think look at those guidelines. I think the ICGP handbook really is an excellent resource. There are other online things, and the NDSS, again, has excellent resources. But I think tailoring it to that individual is really important, and the order in which you put in the medications will vary. And of course, it's not just about glucose, the blood pressure, the lipids, the mental health, all of those aspects. We have to look at them all at once. The blood supply with that glucose in it and the other metabolites, it goes everywhere. So, we need to think about people as a whole.
Thanks, David. Gary, we've heard some great points from you. Is there any last points you want to leave us with?
Yeah, I think the future is now. I would think we've got a fairly good understanding what diabetes requirements are as a whole. The availability of new medications, new technologies is transforming our ability to provide quality care to people. And if you keep up to date with medication technology, but keep the person at the centre, that interconnectivity is going to transform diabetes care. And I'm looking forward to that future.
Fantastic. And Renza, I'd love to give you the last word.
Thank you. Look, I agree with all of this around, person-centred care. I would really urge people to practice that though, because we hear it, it's a buzzword, and unfortunately it's not the reality. Ask a lot of questions. Don't be afraid of silences while people take the time to formulate their response, and really, delve into what people individually need, diabetes is never going to be the most important thing in somebody's life. I can promise you that. So considering where diabetes fits within everything else is really critically important. So we are people first. Help us make diabetes as easy as you possibly can.
Thanks, Renza. A great point to finish on. So I'd like to thank you all for participating in today's panel. I think you'd agree. There's been some excellent insights there, and I hope this has really broadened your perspective on managing diabetes medicines in primary care. It is time for a break now, but when we return, we'll turn our attention to another important topic. That's the transitions of care across the stages and health settings. So enjoy the break, and we'll see you back very soon.